Namaste and good evening, everyone. I welcome you to today's webinar on clinical updating GI and GU malignancies day 2. With immense pleasure, I would like to invite Dr. Nitish Garg. He is Assistant Professor Medical Oncology at Diana Medical College and Hospital, Ludhiana, for the welcome and introductory note. It's over to you, sir.
Thank you, Nishant, and I welcome everyone, all my colleagues, the faculty, and also our sponsors for this second day of the webinar, which will be basically targeting the GU malignancies and the updates in the genitourinary tract, what is happening in the prostate, the RCC, and also the urothelial. These are the usual common malignancies we tend to see. So definitely, and we would like to learn a new things, and definitely there are certain new things which we need to incorporate in our practice now. As the practice is ever changing, there are new molecules which are coming, there are new molecules which are in the pipeline, and there are new additions of adjuvant treatments, new adjuvant treatments. So that is what we are going to learn today. So for the first talk, which is sponsored by AstraZeneca, I would like to invite Dr. Piyush Mehta. So Dr. Piyush is a consultant medical oncologist at Sohana Hospital, Mohali. So I would like to invite Dr. Piyush for his talk on role of PARP inhibitors is in CA prostate. And also I'll like to announce there is a slight change of plan that the second, after this talk, we will have a panel discussion and then we'll have Dr. Kanika as a speaker for immunotherapy in the urothelial carcinoma. Over to you, Dr. Piyush, sir.
So, good evening, everyone. And thank you, Dr. Nitish, for this opportunity. So, Bill, can you share my slides?
Yes, sir.
Shant, are we sharing the slide?
Technical team, I'm not able to share the slide. Please check.
Okay, sir.
So please start. Dr. Piyush, please start. Your mic is unmuted.
Regarding the use of Lynparza in HRR mutated metastatic CRPC. Next slide. So we'll discuss regarding the initial introduction to the prostate cancer and then molecular heterogeneity in the prostate cancer, PARP inhibitors in prostate cancer. We'll discuss profound trial and then the change in the diagnostic landscape and how HRR and HRD they have broadened our widescape for the usage of the PARP inhibitors in prostate cancer. Next slide. So this is about the prostate cancer in India. So we can see that if we look for the incidence and the mortality, most common is being the breast cancer, and then we have a cervix or the uterus, then we have a oral or lip, and then in the fifth it's a prostate cancer. But we can easily see that though the incidence is less, the mortality compared to other malignancies is also less. And if we see the age adjusted incidence rate, most common is being the obviously breast in females, and then lip, oral cavity, and then we have a cervix, uterus, and if you see the age pattern, and then it comes on the last side in males, it's next slide. So with an estimated about 1.4 million new cases and 3,75,000 deaths worldwide, prostate cancer, that is the second most frequent cancer, and that is the fifth leading cause of cancer death among men in 2020. Next slide. So risk of developing a prostate cancer that increases with age, though the incidence that is also increasing in the young men. And it's the most frequently diagnosed in men between the age of 65 to 74, with a median age of 66 years, and 1 in 9 and 1 in 14 globally. A male, they may develop prostate cancer in his lifetime, and the worldwide incidence that continues to increase in young men. And if we see it like from 1990 to 2017, there has been a annual 2% change in the global incidence of all men between 15 to 39. So with more young men being diagnosed with prostate cancer, the importance of overall survival outcome, and the quality of life that increases. And the most common age group being 65 to 75, but we can see that in an age group of like 45 to 54, it's around 8.7% of the patient population. Next slide. So prostate cancer that is comprised of multiple disease states. So we have a localized, like a newly diagnosed disease, or it could be localized disease, newly diagnosed disease, and locally advanced disease, or it could be just because like a rising PSA and biochemical failure after local treatment, or it's non-metastatic CRPC, in which there is rising PSA and the biochemical failure after hormonal therapy. And then we have a metastatic hormone sensitive metastatic prostate cancer, uh, either newly diagnosed or newly diagnosed in metastatic, or it could be the metastatic CRPC, and in which either it has progressed on or after first line of chemotherapy, or symptomatic patient not treated or with or progressed on chemotherapy, or it's minimal asymptomatic patient. Next line. So there is an ongoing need to improve the standard of care for men with metastatic castration-resistant prostate cancer, and multiple systemic options that can be considered for treatment of metastatic CRPC. However, optimal sequencing is not clearly defined, and the outcomes that remain poor. So prostate cancer, that is a common and complex disease, and it is the second most common cancer in men, with over 3 million cases being diagnosed globally, and it's the fifth leading cause of cancer death in men globally, with around 3 lakh and around 58,000 deaths in 2018. And metastatic prostate cancer, that is considered a clinical problem, with 40% of the patients with prostate cancer, they will develop metastatic disease, and advanced prostate cancer that is incurable and reliably progresses and is often fatal. And the 5-year survival in men with metastatic disease is 30%. And how can we improve the standard of care in metastatic CRPC? So that despite a response to initial ADT, the majority of these cancers, they will become castration resistant. And despite significant advances in MRCPC treatment, the median overall survival in the first line setting is only around 3 years. Next slide. So now, we'll discuss about the molecular heterogeneity in the prostate cancer. Next slide. So we know that around 90% of the metastatic CRPC patients, they have genomically aberrant pathways involving AR pathway, PIK3CA, WNT pathway, and the cell cycle related signaling pathways. So in a multi-institutional study, profiling of we see around 150 tumors from metastatic CRPC patients. So around like 71%, they have a like AR pathway aberration, or it's a PI3K kinase pathway signaling, or it's a cell cycle related or DNA repair. So in DNA, we know that it's like BRCA1, BRCA2, ATM, and then we have a CHEK2 and MLH, MSH, and the RAD51. So if we see that this is like in metastatic prostate cancer, so initially we give anti-androgen treatment, and then if a patient develop progression on this, then we call it as a like metastatic castration-resistant prostate cancer. And so the signaling pathway, like around 23% of the mutations, they were identified in DNA repair pathways. Next slide. So the repair pathway, that is homologous recombination repair pathway, that is the mechanism for the repair of a DNA double-stranded breaks. So it is by either base excision repair or by the nucleotide excision repair. So this is like whenever there is any damage, so either the repair is done by the HRR pathway. So it's either if there is a mismatch, so either there is a base mismatch or insertion deletion, then MLH and MSH2 and the DNA double strand breaks. So these are the things which like NHEG, which is non-homologous end joining, which is being done by the ATM, BRCA1, BRCA2, PALP2, CHEK2, RAD51. So this is how the repair pathway is. Next slide. So BRCA2, that is usually the most frequent altered DNA repair gene in prostate cancer. And if you see, it's mutated in around 8.6% in germline, somatic 7.7, then BRCA1 germline 0.9 and somatic 0.9. Then we have ATM CHEK2, either germline or somatic. And so archival and new biopsy is like, so these are the common mutations which are seen in DNA repair genes. Next slide. So NCCN guidelines, they acknowledge prostate cancer, like either as per the risk group, we do molecular and biomarker testing of tumor. And if it is like very low, then that is not recommended. And if it's favorable or intermediate and the life expectancy is expected to be more than or equal to 10 years, then that is indicated. And in high and very high risk, it's not usually recommended. And in the metastatic and regional disease, so if it's then definitely we do testing for HSR and the MSI or the MMR testing. So ESMO guidelines and EU guidelines, they do not currently provide any recommendation for testing, but the Philadelphia Consensus Conference 2017 that supported BRCA2 testing in screening management and informing prognosis or the treatment. Next slide. So now we'll discuss the PARP inhibitors, the how mechanism, and then the profound trial. Next slide. So we know that despite significant progress in the systemic therapy, metastatic castration-resistant prostate cancer that continues to be a lethal, and it's a molecularly heterogeneous disease with around 30% of MRCPC patients, they harbor deleterious alterations in DNA damage repair genes, including those with direct or indirect role in HRR. So these gene alterations, they can confer sensitivity to PARP inhibition, of which BRCA1, 2, and ATM, they are the most well characterized, and anti-tumor activity that has been reported with the PARP inhibitors patient in prostate cancer patients harboring HRR alterations. Next slide. So coming on to profound trial, like the eligibility criteria, it's only after the required failure of the prior treatment of an NHA for metastatic prostate cancer, including metastatic hormone-sensitive prostate cancer and metastatic CRPC. So it's documented evidence of metastatic CRPC and the qualifying HRR mutation in the tumor tissue, and no prior treatment with the PARP inhibitor or any other DNA damaging cytotoxic chemotherapy for prostate cancer, and the performance status either PS0 or 1 or 2. Next. So in this, there were two cohorts. One is the BRCA1 or 2, and they were randomized in 2:1 ratio. And olaparib was used in a dose of 300 milligram twice a day, or in the another we have a physician choice of the treatment and the optional olaparib at the BICA progression that can be used in like another group. And then in cohort B, it's other HRR mutated. So in this, olaparib was used in a similar dosage, and at the time of progression in the physician choice, we can optional olaparib that can be added in these patients. And the second progression, and this is next slide. So primary endpoint being the back. Primary endpoint being the RPFS by BICR, and the secondary being BICR, and the time to disease progression, overall survival, and the safety and tolerability. Next slide. So in HRR gene panel, we have BRCA1, 2, ATM, and in cohort B, those patients with BARD1, BRIP, CDK12, CHEK1, CHEK2, PALB2, and RAD51B, RAD51C, RAD51D, and RAD54L, they were included. And the 15 gene tested are a subset of genes which are in the Foundation 1 comprehensive panel, and the genes were selected based upon the mechanistic role in the HRR, which is homologous recombination pathway. And BRCA1, BRCA2, and ATM, they are best characterized and quite frequently mutated HRR genes in prostate cancer. Hence, they're included in the cohort A, which was used as a primary endpoint and secondary endpoint. Next slide. So the baseline characteristics, they were well balanced between two arms. And if we see in cohort A, in which they have used the mutations of BRCA1, BRCA2, and the ATM. So they were well matched in respect of age and the metastatic disease at the time of initial diagnosis, metastasis at baseline, either the bone-only disease or the visceral metastasis, and the Gleason score, and in patients with any alteration in a single gene, which is BRCA1, BRCA2, ATM, or CDK12, and patients with other comorbidities. So they were well matched in this, and multivariate analysis that adjusted for the previous use of taxane variable disease. So that has been, they all have been well balanced between both cohort A and cohort B in both the subset in the olaparib and in the physician's decision. Next slide. So approximately 1 out of 3 patients, they were taxane naive. 1 by 5 patients out of around 20% patients, they received 2 prior taxane, and around 20% they have used prior NHAs before randomization. And over half of these patients, they had measurable disease at baseline, and the majority were PS either 0 or 1. And there was a higher median baseline PSA in the physician choice arm. However, the in total range, that was balanced between these two arms. And if you see the baseline PSA, so that was around 62 in olaparib and 112 in the physician's choice arm. And the measurable disease, they were relatively it was around 58% and 55% in physician's choice. And other factors, which is performance status and prior use of a new hormonal agent or the previous use of a taxane, they were well matched between these two arms. Next slide. So profound. So this is the genes which were mutated in cohort 1. We know that it's BRCA1 and BRCA2, BRCA2 being the most commonly mutated, and then ATM and the CDK12. And in the cohort B, we have other genes which is like CHEK1, CHEK2, PALB2, RAD51B, RAD51C, D, RAD54L. Next slide. So profound, that met its primary endpoint. So Lynparza that significantly improved RPFS by BICR in patients with alterations in BRCA1, BRCA2, or ATM versus the physician's choice. And if you see with olaparib, the median PFS of around 7.3 versus 3.5 with the physician's choice, and the median difference of around 3.84 with hazard ratio of 0.34. Next slide. So the PFS benefit with olaparib that was seen across pre-specified subgroup in patients with alteration in the BRCA1, 2, or ATM, and the benefit of olaparib over physician's choice of NHA that was maintained across all predefined subgroups with clinically meaningful reduction in the risk of progression or death in olaparib treated patients. And the profound, however, that was not powered to demonstrate difference between the different subgroups. Next. So significantly, the more patients with alteration in BRCA1, 2, or ATM, they had an objective response while on olaparib versus physician choice. And if we see the objective response rate, so it's 33.3% with olaparib versus 2.3% in the physician choice. Next slide. So an interim analysis like olaparib that has shown to be a favorable trend in OS in patients with alterations in BRCA1, 2, or ATM, despite more than 80% crossover for eligible patients, and median OS being around 18.5 in olaparib, and in physician choice it's around 15, and with hazard ratio of 0.64. So difference of over 3 months was seen between arms in OS at an interim analysis. Next slide. So statistically significant and clinically meaningful improvement was seen for BICR assessed RPFS in olaparib versus physician choice treatment in these patients, and the median PFS of around 5.8 versus 3.5, and with a median effective difference of around 2.3 with hazard ratio of 0.49. So olaparib that reduces the risk of progression or death by around 51% versus physician's choice, and the benefit was seen at 6 months as well as 12 months. And the patients with qualifying HRR mutation, they experienced a significant improvement in the median PFS of around 2 to 3 months. Next slide. So the PFS benefit with olaparib that was seen across all the pre-specified subgroup in the overall population in cohort A and B combined. Next slide. So significantly more patients with qualifying alterations in ITT, they had objective response to olaparib versus physician choice, and overall response rate of around 21.7 versus 4.9% in the physician choice. Next slide. So olaparib that demonstrated a statistically significant final OS benefit in patients with alterations in BRCA1 and BRCA2 or ATM versus physician's choice, and olaparib that reduced the risk of death in cohort A by 31% compared with physician choice treatment, despite substantial crossover of the control arm patients to receive olaparib. And with it, the median overall survival is around 19 compared to 14, and with a hazard ratio of 0.69. Next slide. So as we discussed that olaparib demonstrated a statistically significant final OS benefit in patients with alterations in BRCA1, 2, or ATM. And the cohort A with like if we adjusted for the crossover, even then that shows a significant difference and the separation of the curves that can be seen. Next slide. So final OS benefit with olaparib that was seen across all pre-specified subgroup in patients with alterations in these mutations, and that is in all subgroups irrespective of the either sex or the performance status or the any prior treatment, and the baseline PSA, or if it's more than 2% or 2 median 2 reduction, or it's less than that. Next slide. So exploratory gene level analysis that demonstrated RPFS and OS benefit of olaparib versus physician choice in BRCA and other HRR mutated. 97% of these patients, they were randomized based upon alterations in 8 out of 15 genes, and 7 out of 15 genes had alteration frequencies, and that too low for descriptive analysis. Next slide. So olaparib that is associated with better related quality of life and functioning over time compared with physician choice in overall survival. Next slide. Next slide. So OS benefit that was greater with olaparib versus physician choice of the NHA in cohort A and cohort A and B combined, regardless of the prior use of taxane. Next slide. And the median duration of treatment with olaparib in cohort A and B, that was nearly double that of the physician's choice. And if we see that any adverse event which leads on to either reduction or either stoppage of the drug, that was in around 114 patients compared to 244 in the olaparib arm. And side effects of any like grade 3 or higher, they were in around 50% compared to 37% in the physician's arm. And the patient received olaparib for nearly twice as long as the control arm, and which that may have contributed to higher adverse event leading to discontinuation in the olaparib arm. Next slide. So the adverse event profile that was consistent with the known safety profile, which is anemia, nausea, asthenia, fatigue, vomiting, diarrhea, back pain, peripheral edema. And the most common adverse event, they were anemia, fatigue, and nausea. And 4.3% of patients on olaparib, they've experienced pulmonary embolism, and 0.8% with physician choice. And there were no reports of MDS or AML. Next slide. So adverse event, we know that hematological toxicity, it's like in a profound trial, 21.5% they treated with olaparib experienced a grade 3 or anemia and neutropenia, thrombocytopenia, MDS, and AML. So the overall incidence in these patients with clinical trial with monotherapy, that is around less than 1.5%, and no patients were identified with MDS or AML. And pneumonitis, including event with fatal outcome, that has been reported in less than 1% of the patients with olaparib. Next slide. Next. Next slide. So profound patient HRR tissue test success rate. So patient flow through screening for HRR gene alterations with the central NGS at FM Foundation Medicine 1. And patients, they were enrolled, total 4,425 patients, they were entered in the screening, and 4,047 patients with sample tested and reported, and it was around in 69% it was successful, and in 31 that failed. And next slide.
Sir, kindly conclude your talk.
Yeah. Just next slide. Next slide. Just leaving this. Next slide. We have discussed this already. So the prevalence of HRR gene alterations in primary and metastatic disease, like in all metastatic disease and in all primary disease, metastatic, so it's around 32% compared to 27% in the primary tumor. Next slide. Next slide. So test failure, that is a possibility, and the reason being either it's a not adequate tumor content in the tissue sample, or it's a like DNA extraction failure, insufficient DNA yield, or failure after DNA extraction, not quantity not sufficient adequate for the NGS testing. Next slide. Next slide. Next slide. Next slide. Next slide. Leave it. I think we finished it. Next slide. So this is a NCCN recommendations for the testing. And coming on to last summary, like in patients with metastatic castration-resistant prostate cancer with disease progression on prior NHA, olaparib that provided a statistically significant and clinically meaningful improvement in BICR compared with physicians' choice of enzalutamide or abiraterone plus prednisolone, and it improved multiple clinical and patient-related endpoint, which is overall response rate and PFS, and the benefit of olaparib over NHA that was independent of the prior use of taxane in metastatic CRPC in patients with alterations in the BRCA1, 2, or ATM, or in other genes, as we have discussed. And it is well tolerated with a safety profile consistent with that seen in other cancers. And the profound, that is the first positive biomarker selected phase 3 study evaluating a targeted therapy in men with metastatic CRPC and olaparib. That is the only PARP inhibitor to improve OS versus NHA in HRR mutated metastatic CRPC, highlighting the importance of genomic testing in this patient population. Next slide. I think this is last slide. Thank you.
Thank you, Dr. Piyush, for that wonderful talk on olaparib and how the genomic profiling of the tumor is so important. So just one comment, if we have gone through this data, we can see that BRCA2 is the most common. And unfortunately, if there is a BRCA1 mutation, the responses are slightly less than the comparison with the BRCA2, CHEK2, then CDK12 and ATM. So that is, I think, the point to remember. Most common is BRCA2 and the mutations. If it is BRCA1, just be slightly skeptical about using gulaparib in these kind of a situations. And other thing is HRR testing. Usually we tend to do on the blood, but even on the tissue, it has been approved. How many places it has been done, I'm not very sure. So next session, we will be moving on to a case-based panel discussion, which is the management of metastatic CRPC. And I would like to invite my moderator, Dr. Chitresh Agarwal, sir. Sir is Senior Consultant Medical Oncologist at Forest Hospital, Panchkula. So I would like to invite sir, and sir can call upon his panelists. Over to you, sir.
So good evening all. Thank you, Dr. Nitish. I will like to invite my panelists. Are my panelists there? So I think Dr. Satyankar, Dr. Deepak Bharti.
Yes, I'm there.
So who else would be my panelist? Kindly share the names.
Dr. Mubin Mittal is not there. Dr. Deepak Bharti, Dr. Nitish Garg, and Dr. Satyankar Gupta is here.
Okay, done. So I think this is a case provided by the outside slides. We'll not go into the detail of each and every slide, but let us start with a case-based panel discussion where we are going to discuss about a 60-year-old male with no family history of malignancy. He came with complaints of dysuria and pelvic pain in May 2018. An ultrasound showed prostatomegaly with significant post-voidal urine. He underwent an MRI of LS spine, which was suggestive of skeletal mets at various places. His PSA was 17. He underwent a prostate biopsy, which showed adenocarcinoma of the prostate with Gleason's of 4+4. And he underwent a PSMA PET CT, which showed a metastatic disease. So I would start with Dr. Satyankar. Dr. Satyankar, this is all what we have done for this patient. If such a similar profile of patient comes to you tomorrow morning, you follow the same routine or you would differ in your evaluation approach?
Largely, it's the same. Largely, it's the same. I think it has been adequately investigated.
Okay, so just a question from my side is that if your MRI LS spine is showing metastasis, will you still press for a PSMA PET CT scan, or
Because
an ordinary PET CT scan would also do for your patient?
No, ordinary can do, but for if it's a low Gleason score, 6 or 7, then probably PSMA PET helps us more as compared to the conventional PET. But just to complete the metastatic workup in this case, because it was only MRI lumbosacral spine and not the systemic evaluation. So some sort of systemic imaging has to be done, and PSMA PET is fairly justified, not a major issue.
Dr. Nitish, any comment or you agree?
I think it is okay, sir. But yes, FTG PET would also be okay. I would also like to add upon like a uroflowmetry because of dysuria, and maybe a MPMRI prostate to look at what is happening, and then maybe I might skip out on doing a PET CT.
Oh, interesting. So you do MP-MRI prostate for all of your patients, or how do you choose amongst
Not
these
usually.
situations?
The symptoms concerned here are dysuria, pelvic pain with the PSA, which is not very high. So, looking at these three or four, the history and the blood workup findings, not very convinced on jumping onto a metastatic workup upfront. So, yes, I would like to do a MT-MRI if the patient has a significant PVRU with the prostatomegaly. So that is the first thing which I would like to do here.
Dr. Deepak?
Okay, so good evening, everyone. So there are two things. Either we want to know that patient have underwent MRI lumbosacral spine prior to PSM PET. I think someone has done that because patient is complaining of backache. I am right for that. It's just matter that how the patient comes to you. If patient comes to you with all these symptoms with PSA high, obviously everyone will go with MP MRI only for upfront only. But in this scenario, patient already has done the MRI is lumbosacral spine, and we know that metastases are there, and we are right to do PSA PET at this point of time. Otherwise, if you ask, patient comes to us with USG, with urology opinion, with PSA, obviously everyone has gone with MP MRI only, and after that, looking the things with the biopsy, then they go for the PSMA PET, if you ask me. But if someone has already done metastatic workup or something odd features with backache and already MRI is showing the metastatic deposits, we can go for PSMA PET at that point, but we can skip MRI at this point of time.
Okay, so for all practical purposes, we are dealing now with a 60-year-old male with a metastatic prostate adenocarcinoma and locally advanced disease with skeletal metastasis. So what is the plan of treatment? Dr. Satyankar?
So patient has diffuse bony metastasis, multiple level bony metastasis. So if the affordability is okay, then we can, use straight away some kind of androgen deprivation therapy, either surgical castration or this what you call Digerelix. We can use that. Or if the affordability is an issue, then first we have to give this bicalutamide for 7 to 10 days, and then probably we'll add LHRH based agonist.
So, in what set of patients you tend to add biglutamide initially and then switch over to an antagonist or an agonist? How do you choose, or is it your common practice to do so?
No. Suppose the patient has, features of cord compression or diffuse bony metastasis, where we can have, testosterone flare. So just to compensate that, we can do. We need to give bicalutamide.
So this is very interesting. Like, I would just like to understand that in your day-to-day practice or your clinical experience, how many patients actually land up with a flare phenomenon, or how many patients do you see with flare phenomena in your practice?
Haven't seen, but that's what the standard teaching is. But in this patient, at times they do also go into urinary retention also. So that is also one indication to use.
So you would start with, I suppose, either a biglutamide followed by an ADT or an ADT upfront.
Yeah.
Correct.
Yeah.
And in addition to ADT, you would use.
I would, like to add one molecule. Either this patient is diabetic or not. It's, I think, non-diabetic.
So he's non-diabetic, non-hypertensive,
Yeah.
ECOG 1.
So the patient has, according to some criteria, he has some high risk features. Gleason score is high, 8, and then there is this multiple bony metastasis. 2 or 3 are above the extraction. So I think I would like to give him docetaxel for 6 cycles as per the charted trial, because that's a finite therapy as compared to the other two drugs, either Enza or this abiraterone, which are infinite.
So valid option. Dr. Nitish, in your practice, how many percentage of patients are you able to convince at this point for chemotherapy? Or most of your patients end up taking the non-chemotherapy options?
I think that, sir, with this age, I would like to prefer and I convince my patients for chemotherapy because of the younger age of presentation and the higher glycemic score and the aggressive disease. So, though the disease has multiple metastases, fits into a high volume disease, almost full of the skeleton is involved. And here I would like to add on abiraterone also as per the Stampede data, the recent most data, where ADT, docetaxel, and Stampede has shown a better response. Stop docetaxel after 6 and continue ADT and abiraterone longer. So the overall survival difference has improved by approximately 10 to 9 to 10 months here.
So have you used this combination in a clinical practice till now?
Yes,
Or
I have
you,
used it in one patient. Yes.
one patient. Dr. Deepak, do you end up using a combo of all these drugs upfront, or do you reserve all this for sequential treatments?
I am a reserve person. I used to get the reserve things. I will start the sequential treatment only. Basically, at this present, because patient is a low volume disease, it is not a high volume disease as per trial criteria. So we can use ADT with any hormone therapy. Either of them will work in this case. Both are right, either Biraton or enzalutamide. But as far as my concern, I started with Abira and then I go to Enza. I'm not doing the reverse, because what they told that if Enza will start upfront, Abira will won't work after that, as per the theoretical point of view. So I will start ADT with the Abira and with zoledronic acid or denosumab, whatever we can use for bone medicine.
Will we lose connection somewhere?
Am I audible?
No, it's fine.
Yes, sir. Now it's better.
Dr. Chitresh, what I told, it's audible to you, or I repeat my lines?
No, I understood. But just my question was that, do you use bone modifying agents upfront in for every patient, or you reserve bone modifying agents once the patients are progressing toward castration resistant stage?
No. It all depends on what kind of patient pain score is, and most of patients, as we told, that patient is upfront, patient has backache and is getting symptoms of all these things. I tend to use upfront only.
So I think the panel has come to this conclusion that for this patient, they would end up using ADT plus minus abiraterone or enzalutamide, preferably abiraterone, and a bone modifying agent for his bone predominant disease.
But
I think
so-
the trial showed that there is no benefit of addition.
No survival
of
advantage of
NHS.
using a
Yes.
bone
So
modifying
it-
agent in castration
if-
sensitive setting.
Yes.
But
So if there
we
is
all
a
have to agree that
radiological-
for practical purposes,
that does not
most of
stand
us
true if
end
the
up
patient
using the
is-
bone modifying agents.
Yes. Right.
And especially if a patient is having a bone predominant disease, it's symptomatic bone disease. I think most of us all agree that we end up using the bone modifying agents despite knowing this very clearly, that there is no survival advantage in castration sensitive setting. So I think that is a point where we make these decisions based on the cost, the understanding of the patient, and how well the patient is educated in front of us. But I have seen, at least in our practice, that many times in castration sensitive settings also, we end up using with bone modifying agents. So moving on to the next point about this testing that is of the nowadays the latest trend in prostate cancer, the genetic testing in prostate cancer. First of all, I would like to understand from all of you, and Dr. Nitish probably can answer this, in your actual clinical practice, how relevant or how seriously you take a family history of prostate cancer, and how many patients actually have a relevant prostate cancer history in most of your prostate cancer patients?
The relevant history, I don't think we tend to uh, get that out of the patient even after so much of digging. Yes, I tend to ask about the pancreatic, breast, ovarian, along with the prostatic cancer history, because these are the all BRCA mutated malignancies. And if the patient is young, less than 70, I tend to advise them that this is the possible test which we should be doing upfront. HRR ideally on blood plus minus tissue. MSI maybe if the disease has a high glycine score and also the PSA is very high. But usually I tend to reserve MSI for a later on setup, not in the upfront setting.
So
the percentage wise, if I say, I'll say percentage wise, the patient will give me a history only about in 20 or 25% of cases that they have a history. Otherwise, there is no specific history given. It
So
is
you mean to
usually
say
not.
in your practice, 1 in 4 patients who are diagnosed with prostate cancer would have a relevant, some form of family history.
So, yes,
Pardon?
not pertaining to the prostate per se, maybe a
Correct, but some
breast
form of
or
syndromic approach could be
yes,
there. And Dr.
yes.
Satyankar, you would agree or you would differ?
Yeah, I agree. I'm currently having two families, I mean, two patients who have 3 generations are having CA prostate. But yet, in spite of everything, I have not been able to convince them to get the HRR testing done. So they don't get tested that frequently in spite of counseling.
And what is the most common constraint or limitation that you come across?
I don't know, people, fear, anxiety, additional tests, and they don't want somehow all these patients, not just with prostate, with breast.
Dr. Satyankar, they have already taken the opinion and they want these tests, and I have also given the option of giving these
Yeah,
things
okay,
because
in ECHS, yeah.
that lady wants to do all the things, but somehow they are getting fear about the things that it will become positive, then I will get the side, something like that. Fear factor is there in the family.
Yeah, that is the only, uh, factor which restrains them from getting tested.
Because it's not the
So,
1%, 2%, it's all the 3 generations, and they definitely
Yeah.
believe that we will get positive on that. They definitely believe that.
so Dr. Deepak, when do you do a genetic testing in your patients, or in this particular patient, when would you do a genetic testing?
So, if you ask me what I'm doing prior to last year, I am doing after failure of two lines of therapy. But nowadays, I'm doing after failure of first line of therapy.
And what test you order?
There are two tests which we are ordering otherwise around. One is NGS. I'm doing other way around because it covers BRCA1, 2, and ATM, all of the genes. And if that comes back, then I do the HRD. If I'm not able to find that.
Okay, so
Because
you first do BRCA and then you test for HRD.
just I do NGS. It will include all comprehensive panel, including all of the targets. And if I'm not able to do ATM or BRCA1 or 2 is not there, then I will do in future independent HRD also.
Dr. Nitish, you agree or you tend to follow some other algorithm?
I tend to follow HRR, if not only BRCA1 and 2 germline first. If it is negative, maybe a somatic ctDNA. I think the role is not yet very clear, and HRD testing for prostate is in under process. Maybe we
Dr.
might
Satyankar?
get to know the results soon. Is it of
I
benefit
think
or not?
I prefer to advise HRR testing, both germline and somatic in one go. Not just it has hereditary implications, but therapeutic also. So I think we should get it done as soon as possible because later on tissue will exhaust and patients will go for repeat biopsies.
Correct. So I think in my practice also, I first of all would go for an HRR, and then if it all comes out to be negative, then probably we'll end up using a BRCA1 too. So I do not use CT. I have not used ctDNA till now for prostate cancer. Has anyone used it, or what is your experience of usage of ctDNA?
Not really.
Not yet.
So this is the rationale behind this germline mechanisms that we all have discussed,
So
because
there are
around
two.
12%.
Dr. Chitresh, I just want query for that. If we know that in the profound trial, only 3 mutations have shown the response rates, ATM, BRCA1, and 2. Rest all are not showing any survival benefits for olaparib.
Correct.
And all 3 are we are getting from NGS. All 3 were getting from
Correct.
NGS. I'm just asking that we know that HR mutations still can work and we can still tirazoparib, olaparib, we can still do.
No, I am not saying that your approach is wrong. My only point is that
No, no.
not many patients actually end up taking an NGS so easily. So
Okay.
we first do a basic limited HRR sort of a thing, and then counsel them for BRCA1, BRCA2.
Okay.
So this all, I think we all have learned, and we already know about this. So these are the the set of patients who have a positive family history, who have a known mutation, and people who have intermediate or high risk localized prostate cancer, or a metastatic prostate cancer, or a biochemical relapse. So, I was going through the guidelines. They also recommend this genetic testing for people who have high risk localized or intermediate high risk localized prostate cancers. So, Dr. Nitish, for this subgroup of patients also in your practice, do you do genetic testing or you wait for the metastatic setting to come and then only you send all these tests?
So definitely, sir, the way they have been put up in a high risk group is because the chances of reoccurrences are high. And if we have a upfront evaluation of the disease, the molecular basis, we tend to know how it is going to behave, and we can use these drugs. And I do tend to prefer doing the molecular testing. So there has been, I believe, Oncotype DX. Here it is Oncotype DX 2015 gene or something like that, or a cipher. There are few molecular testing names which comes up with a recurrence score. So that is what the molecular testing, the trials have been looking at here. So those
Correct.
are
So
the
the only message
deciphers.
why I brought this up was that, our while practice, while seeing day-to-day patients, this genetic testing, this germline testing, this only it comes to our mind when we start seeing the metastatic setting.
Yeah.
The message is that for patients who are, high risk locally advanced or high risk diseases in non-metastatic setting also, we are moving at, the times have come when for this group of patients also, we should start looking for all these mutations and germline mutations, because that is the way forward. And at least for me, I can say that I am not doing it regularly for this group of patients till now, but now I should actually, move to this group of diseases also. So moving on, this patient was started on hormonal therapy with degarelix and a chemotherapy with docetaxel 3 weekly. Post 3 cycles, his PSA was 2.5. PSMA PET after 4 cycles showed a very good response. He completed 8 cycles of docetaxel on October 2018. PSA was 0.9 and he was continued on monthly degarelix. So any preferences here of monthly degarelix versus 3 monthly leuprolide or any GnRH analogs?
I think now it's good enough time we can switch over, because it has been seen that switching over from a antagonist to agonist will not flare up the disease at this point of time. So instead of poking a needle in a person every monthly, giving it a 3 monthly or a 6 monthly regimen may help. The
And anyone
compliance will become better.
using oral relugolix now?
As of now, no. I have not used it. Sir.
Dr. Deepak?
Not yet. We're planning
Not
to
yet.
start.
No, no.
No. Okay.
No.
So 2019, there was increasing in the symptoms of urinary complaints and sacral pain, rising PSA to 5. He again underwent a biopsy and it was sent for NGS by Foundation 1 and the patient reported ATM loss in exons 46 to 63. So first of all, I would like to ask, if a patient has underwent treatment, he has completed treatment and say at the end of 1 year, he is experiencing the relapse symptoms again, how many percentage of patients you would subject to a repeat biopsy? Dr. Satyankar?
No. In prostate, I don't think. Just in case there is discordance with PSA and we are suspecting small cell, kind of transformation, or there is predominant visceral disease without any rise of PSA, then we might do. Otherwise, I don't think. Like in this case, probably the tissue might have exhausted and they wanted this, gene testing done. So that is also one indication.
But to start with, you remember his PSA was never very elevated. It was only 70.
No, it was, yeah, it was. But there was histopathologically, it was proven that it is adenocarcinoma and not small cell. So
correct. So for some patients who don't present with a very high PSA, still an adenocarcinoma on a biopsy, on a relapse, would you go for a repeat biopsy or you would stick to adenocarcinoma and continue the same way?
no, but on relapse also, if the PSA is pretty low, then we might repeat it. We are justified in doing that.
Dr. Nitish?
I think, sir, the duration of the recurrence-free survival is quite small here. 12 to 15 months will not change the nature of the disease, and doing a repeat biopsy may not be of any benefit. Yes, definitely, if the symptoms are too many and the PSA has not risen, then maybe I might think of, otherwise I won't.
So as a general practice, we all will agree that we do not subject our patients to a repeat biopsy until unless there is a gross discordance or
Yes.
we have something else in mind.
Just if disease is low PSA and disease is DFI less than 6 months, then definitely we have to repeat the biopsy. And last year I have done in one patient, and he has converted to neuroendocrine after adenocarcinoma because the
Correct.
PSA is
So,
always doesn't
because
flow.
on progression mechanism, some of these adenocarcinomas would actually have progressed to a neuroendocrine differentiation. So that is
Yes.
why I wanted to ask you that how many patients you would actually subject to a repeat biopsy.
So it's only if someone present with low PSA, if still after radiology progression, still having low PSA and DFI is less than 6 months, these are 2-3 factors where we have to think about that.
Okay, agreed upon. So this patient's report came as to be ATM loss in exons 46 to 63. Dr. Deepak, how will you treat it?
You are talking about 2019 or 2018? Because at that time, profound trial was not there.
We are talking of 2024, tomorrow morning. This patient is going to come with
Okay.
a bag full of money to
Okay.
you.
Okay, definitely, because patient has responded to chemotherapy, and after that, I'm not going for the combination therapy. I will stick with olaparib only. And if patient is showing good response after 2 or 3 months, I definitely continue with a single agent only. Or if something is not there, not getting the adequate response, then I can add one more hormone with that olaparib.
So will everyone start on olaparib tomorrow morning, Dr. Satyankar?
So,
I think we are justified. We are
justified. We are
Sir-
justified in offering olaparib. My question is, in your practice, would you end up using olaparib or you would still go the standard way?
No, sir, there are two things in that. There are two things in that because patient has already received first line docetaxel. If it's the case where upfront we're getting ATM mutation, we definitely won't put patient on olaparib on first line. It's the second line, and as per the trial criteria, as well we getting the NGS and we getting the foundation one, we got the target. Definitely, we want to target this point of time, and either with combination of single agent, it all matters whether the disease and other way around.
So Dr.
I
Deepak
think better
will
continue
definitely
with
go
the.
for olaparib tomorrow morning. Dr. Nitish?
I
Okay.
think I will stick to my newer, not so newer, the hormonal agents, because the profound trial has shown that these two drugs have been used previously, and also the docetaxel, and I'll reserve olaparib to achieve a longer PFS in the patient.
Correct. So I think nobody has a clear algorithm here. Probably the way we are trying to treat the diseases nowadays, this all genetic testing all would tempt us to use olaparib, but I don't know the real answer here because probably I would not end up using olaparib so early for this patient, and I don't have a strong reason or a rationale behind it.
The
But
point is that if we not have to use olaparib, then why we have ordered the test at this point of time? What we have to ask the patient? Why? My point is that.
no, sir, agreed. So there is no problem in your approach, and rather we should encourage for the use of these targeted drugs with the use of the NGS reports. But I think what we discuss and what we see actually in our clinical practice is that till and most of the conventional approaches have been exhausted.
Exhausted.
Still, there is a limitation from the medical oncologist sometimes to first complete the standardized treatments and go to all these targeted approaches. This is at least what I feel. There is a difference of opinion, and I think both approaches are acceptable. Dr. Satyankar?
Yeah, I totally agree with you. Yeah.
So this is the NCCN guidelines. This is a version 2022, which is a slightly older version. We have moved on from these. So I would not stick to this. This all trial data we have learned and seen number of times. So this, I don't know why, but considering his progressive disease, he was restarted with chemotherapy, docetaxel and carboplatin regimen, 3 weekly and monthly pharmagon. Anybody would stick to this approach?
No. No.
Not really.
So
Docetaxel can be rechallenged, sir, but it's
After 2
too
years.
soon to rechallenge. And carboplatin, I'm not sure if it would have been a neuroendocrine transformation or
probably,
something like that.
yeah. So I think the only setting where we might have thought of this regimen if we have a convincing neuroendocrine differentiation report Otherwise, I think we all agree that this would not have been at least our approach in this set of patient. And this patient post this had a PSA of 2. PSM is good after 5 cycles. And strangely, after this, he was started on abiraterone and he's doing well. So I do not know what to ask and how to frame this, line of treatment from this point. So,
Dr. Chitresh, request to you, please conclude your talk in next 2 minutes.
Yeah. So I am more than happy to conclude. Just 1 or 2 slides. We'll not go to case number 2. So I think what we have understood is that, genetic testing is important. Genetic testing we tend to use early in metastatic patients, but we also have to consider for patients who are either locally advanced high risk or intermediate risk. And with the advent of all these NGS reports and HRR reports that we see, there is an increasing role of PARP inhibitors either alone or in combination with the standardized therapies. And we all should be able to use these therapies more and more. Thank you.
Thank you, sir, for the wonderful moderation and very lively discussion on PARP inhibitors in prostate. And definitely the case had some mix and matches here and there. But yes, we all agree that our approach is according to the guidelines and the way we approach it. And the PARP inhibitors can be used early, but can also be reserved for later lines. So thanks a lot, sir. And
Thanks, Dr.
moving on
Nitish.
to
Thanks.
thank you, sir. Moving on to our next session. So switching over from a prostate and going up the urogenital tract into the bladder. So we'll be having a discussion talks on the urothelial bladder malignancies. So I would like to invite Dr. Kanika to talk on the role of immunotherapy in the bladder malignancies. Dr. Kanika is consultant medical oncologist at Max Hospital, Mohali. Over to you, Dr. Kanika.
Hi, Nitish. And
Hi. How are you?
hi, I'm good. Thank you for inviting me and letting me part of this webinar. As you have said that I'll be starting with the urothelial cancers. Just a minute. Is my slide visible?
Yes, ma'am. Slide.
So coming to the recent advances in the metastatic urothelial cancer. So a small disclaimer that it is a non-promotional meeting and this is just the scientific data that we are discussing. So when we talk about the bladder cancer, so like lung cancer, kidney and the melanomas which has moved away from chemotherapy towards immunotherapy, I think urinary bladder is also following the same because after GEM-CIS, we don't have much option in the chemotherapy. And now we have numbers of agents that are approved in bladder cancer in the upfront setting, in the second line setting and PD-L1 positive, irrespective of the status. So there are various agents that are approved. Starting from the basics. So again, when we talk about the 5-year survival rate with metastatic disease, so they have a poor overall survival, and the patients who upfront present with the metastatic disease, so they have around 5% 5-year survival, and they are generally incurable. And the proportion of diagnosis is slightly higher in our setting because of delay in the starting of treatment or in diagnosis. So it's around I would say 20 to 25% of the patients in at least my setting. So again, when we plan the treatment in bladder cancer, so it is based on whether the patient is platinum eligible or platinum ineligible based on the baseline kidney function test. So we have a very limited options in the first line setting. So if the patient is cisplatin eligible, so they are usually started with gemcitabine cisplatin based therapy. I have never used dose-dense MVAC regimen because of the toxicity associated with it. And GemCis is a relatively well-tolerated regimen followed by avelumab maintenance, which is the standard of care now. If the patient is cisplatin ineligible, then carboplatin-based regimen can be used along with gemcitabine followed by avelumab maintenance. Or in the first line, if the patient is elderly with a poor performance status, you can also start with atezolizumab or pembrolizumab in the PD-L1 positive patients and any platinum ineligible patients, irrespective of the PD-L1 status. So when we talk about the data associated with gemcitabine cisplatin, so in cisplatin eligible patient, it is 14 to 15 months, and with gem carbo, it is less than 10 months. So in urinary bladder, actually the gemcitabine cisplatin is not it is placeable with carboplatin. So carboplatin is inferior, and if the patient is not eligible for cisplatin, it's better to add some higher efficacy agents to it. So again, there was no improvement in the standard of care for the first line setting for over 30 years. So starting from 1980s, when cisplatin became the standard of care for the first line, till we said till 2017, there's still the regimen was gemcitabine cisplatin. We kept the patient on follow-up, and on progression, we will give a taxane-based regimen for the second line setting. Then in 2017, FDA and EMA approved the for cisplatin ineligible patient atezolizumab and pembrolizumab. Followed by the further 2019, there was a positive phase 3 trial of atezolizumab plus chemotherapy. And from 2020, the first line maintenance therapy is avelumab after the chemotherapy. So when we talk about the IM Vigor 210 trial, that is a phase 2 single arm study of atezolizumab in metastatic urothelial cancer. So they have taken patients who are metastatic transitional cell carcinoma. They have taken the tissue blocks for PD-L1 analysis, and it is upfront setting and no prior treatment for metastatic, and at least 1 year gap since the perioperative chemotherapy. So they have given atezolizumab till the disease progression, and the primary endpoint was overall response rate. So when we see in the patients, 119 patients were enrolled, and the overall response rate was around 24%. The duration of response was not reached. So the median OS, it also increased from 14.8 months to 16.3 months after 30 months of follow-up. So duration of response in the responders, so in the 24 patients that have a response, so as we can see, most of the patients, they have more than 2 years of response in the patients who have. So that is the patients with CR as the best response, and they have the prolonged sustained response in the patient. So as we say with immunotherapy, there are the response rate are less, but the patients who actually respond, they have a long-term control rate with immunotherapy. So even in elderly patients, more than 75 years also, the response rate is 21.4% because of the increased rate of tolerability of these agents. And that is a relatively good figure. The next is the Keynote 052 trial. That is a phase 2 study of pembrolizumab in cisplatin ineligible patients. So they have taken again metastatic or unresectable carcinomas of the renal pelvis, ureter, bladder, or urethra, no prior systemic therapy, and the ineligible for cisplatin. Either they have low creatinine clearance, advanced ECOG performance status, more than grade 2 peripheral neuropathy or hearing loss, or they have a class 3 heart failure. So they were given pembrolizumab. And again, they have checked for overall response rate in all the patients, and also have done subgroup analysis for PD-L1 expression. So as we can see that the overall response rate, the total 106 patients, and they are around 30% overall response rate was seen. And in the patients who have a CPS score of more than equal to 10%, That is, the overall response is seen in 47% of the patients. So even 9% and 20% of the patients have CR in PD-L1 positive patient. That is the high CPS score. So PFS, when we talk about in all the patients, it is at 1 year, 22%. OS is 31% at 2 years. And in the PD-L1 positive, it is 47% at 2 years, as compared to 24% at 2 years and less. So in the specific subgroup of PD-L1 positive patients cisplatin ineligible, immunotherapy can be considered as a first line. Then come the Javelin Bladder 100 trial. That is a phase 3 maintenance avelumab plus best supportive care after the first-line platinum-based chemotherapy in the cisplatin eligible or ineligible patients. So they have taken histologically confirmed unresectable locally advanced or metastatic transitional cell carcinoma, and the patients who have response, either a CR, PR, or a stable disease with the first-line treatment. So around 700 patients, that is a large chunk of patients, were taken. And treatment-free interval is 4 to 10 weeks after the completion. They have randomized into 1:1 to avelumab plus best supportive care or just best supportive care, and the patients were kept on follow-up. Again, the treatment was continued until progressive disease, unacceptable adverse effects, or withdrawal. And the primary endpoint was overall survival in all the randomized patients and in PD-L1 positive subgroup. So when we compared the both arm in the overall population, there was a significant difference when we talk about the follow-up alone versus avelumab maintenance. That is 14 versus a 21 month, around 7-month benefit was there. And when we talk about the PD-L1 positive subgroup, it was not reached in the avelumab arm, and it was 17.1 months in the follow-up patient. So that was significantly higher. And when we talk about the bladder cancer, which is a highly aggressive tumor presenting with a stage 4 disease, at around 2 years also 70% of the patients, they were alive and they have not progressed. So that is a good sign for the specific subgroup of a bladder cancer. So when we talk about the progression-free survival, it was 3.7 months versus 2 months with the avelumab in the overall population. And in the PD-L1 positive, it is 7.5 months versus 2.1 months. So when we talk about the second line treatment in bladder cancer, again, there was no improvement for the prior platinum exposure after the 2000s. And the first breakthrough came in 2016 with the trial of atezolizumab, followed by the other agent. So we have now a number of immunotherapy approved in the bladder setting, that is the atezo, pembro, nivo, avelumab, and the durvalumab, that are all FDA approved. And again, since it's the era of precision medicine, so based on that NGS report, if the patient have FGFR mutation or other, you can start erdafitinib, that is an FGFR2 and 3 mutation targeted agent, or enfortumab vedotin. So coming to the trials of these agents, so when we talk about the atezolizumab in the second line setting, that is the IMvigor 210, that is again a phase 2 trial that was done. And as we can see that the overall response rate is 16%, with 7% of the patients achieving CR in this setting. And the median duration of response in the patients with CR is 30.5 months. So the median duration of CR in months is 28.4 months. So as we can see in this, that at 2 years also, more than 2 years, the patients who have initial response, they were controlled on even on follow-up. So overall response rate by PD-L1 status, they have a shorter duration of follow-up compared with the intention to treat. But when we see the PD-L1 positive subgroup, the figures are even higher in the patients as compared to the intention to treat population. So with a median follow-up of 32.9 months, atezolizumab demonstrated continued efficacy and a long-term survival benefits in the subgroup of a second-line setting with a median overall survival of 7.9 months and a 1-year overall survival of 37%. So that then IMvigor 211, which is a phase 3 trial of atezolizumab in previously treated metastatic urothelial bladder cancer. So in this 1 to 2 prior lines of platinum-based chemotherapy, the patient have received with a good performance status. And again, the block was used for the PD-L1 analysis by IHC. So they have randomized the patient to atezolizumab versus chemotherapy, that is the taxanes, that is the investigator choice of chemotherapy. And they were stratified by the chemotherapy regimen, PD-L1 status, number of risk factors, and the liver metastasis. And they have used Ventana SP143 IHC assays for the PD-L1 expression on the tumor-infiltrating immune cells. So based on the result of this trial, the atezolizumab have gained approval for the prior platinum exposure in metastatic setting. So when we talk about the overall survival in intention to treat population, median overall survival, there was 8.6 versus 8 months when compared to chemotherapy. So that was not much of a difference. But when we see in the specific subgroup, so the graph started separating and there is a minimal difference between the two arms. So again, the 24 months overall survival rates were 23% with atezolizumab and 13% with the chemotherapy. So initially the graphs were overlapping, but in the patients, again, as we were discussing, who have initial response, they continue to show a sustained response over the period of time. So coming on the overall survival by treatment and chemotherapy subgroup. So in the taxane subgroup, when compared with the atezo, there was a benefit of 8.3 months versus 7.5. And when we talk about the vinflunin subgroup, I don't know how many of we are using this regimen. So it is around 1 month benefit with the chemotherapy. So again, the 24 and 30 months overall survival were 24% and 20% respectively. And in the vinflunin arm, it was 21 and 16% respectively at 2 years and 2.5 years. So then come the SOL, that is a phase 3B safety study of atezolizumab in metastatic setting after failure on prior combination therapy. So these were pre-treated patients of metastatic bladder cancer, non-measurable disease, progression on prior non-platinum treatment. So patients who were started on some other regimen with a creatinine clearance of more than 15 ml and stable CNS metastasis. So they were given atezolizumab till there was unacceptable toxicity or death or progression. So in this safety study, they have seen that the atezolizumab appeared tolerable even in the complex comorbid population. So even patients who have renal impairment or who have autoimmune disease or concomitant steroids. So in all these subgroup also, the patients have well tolerated with the grade 5 toxicity seen in a less number of patients as compared to the overall population. So when we talk about the PFS and OS in this, so progression-free survival, the median progression-free survival was 2.2 months and the median overall survival was 8.7 months in this setting. So based on according to age, so when we see there was not much of a difference in the either value based on the advancing age of these patients. Sorry. So according to age and the PD-L1 status, the overall survival was similar across all the age group. So even in the patient of more than 80 years or 65 years, and it was more favorable in the patients who were PD-L1 positive as compared to the negative subgroup. Now, coming to the Keynote 05 trial, that is a phase 3 study of pembrolizumab in the cisplatin ineligible setting. So they have taken transitional cell predominant patients who have progressed after 1 to 2 lines of therapy. And again, they have also randomized to pembrolizumab versus the investigator choice of chemotherapy. And data from this trial, they have supported the FDA approval of pembrolizumab. So when we talk about the overall survival, again, there was a significant difference when we talk about the addition of pembrolizumab, as we were discussing in the previous trial. So at 2 years, the overall survival, it was 27 months versus 14 months. And at 3 years overall survival, there was doubling of the data, that is the 20.7 versus 11 months person. And in the progression-free survival also, at 2 years, it was 12.8% versus 3%, and at 3 years, it was 10 versus 2. So as you can see, these graphs are separating significantly, and there was a sustained response. So concluding, the management of recurrent locally advanced or metastatic, it includes PD-L1, L1 and PD-1 inhibitors and targeted therapy, the choice of which depends on the previous treatments in the perioperative setting, whether the patient have received the maintenance immunotherapy or not. So the approval of 3 immune checkpoint in the first line and 5 immune check in the prior platinum setting, they have changed the treatment paradigm. So atezo, pembro, evolumab, they have shown clinically significant outcomes. The SOL trial of atezolizumab is the largest prospective trial of immunotherapy, reflecting the real-world population and the safety data with this agent. And there were emerging treatment options such as enfortumumab that have demonstrated good clinical efficacy in the first-line setting. So thank you so much for your patient listening.
Thank you, Dr. Kanika, for this wonderful talk. And I would like to add upon that there is a recent data on evolumab, the Avalanche trial, which has shown the real-world data, the responses with Avalanche as a switch maintenance, the evolumab with as a switch maintenance has shown a great benefit. And in the second line, yes, Pembro has done a huge benefit even as a single line without docetaxel. We tend to use it irrespective of the PDL1 status, I believe, and the responses have been good. But what after these 2 lines, or if we have given chemo and immuno, what is next? That is what we are going to discuss now. So then comes the era of precision medicine, and thank you for setting the context and finishing it with the bang that enfortumab vedotin plus idrafitinib has to be discussed after this. Thank you. Thanks a lot.
Yeah. Thanks.
So next we will be discussing on a trial which has recently come up in ASCO GU, which is the combination of idrafitinib with FGFR inhibitor. So the sequencing of that trial and the responses after the progression of the initial therapy. So that is the trial which we will be talking about, the UNIT trial. So I would like to share my presentation for that, and we will. So I think my slides are moving and my presentation is visible. So it's a quick abstract which has come up at ASCO GU24. So idrafitinib and enfortumab vedotin sequencing in the patients with FGFR2 or 3 altered advanced urothelial carcinomas. So the UNITE database retrospective analysis. So this is my disclaimer. So advanced the bladder malignancies, what next after chemotherapy and evolumab, or nivo plus chemotherapy, or immunotherapy plus chemotherapy in form of Atizo or Pembro. What that is the main question here. The relapses, when they happen, they are associated with a dismal outcome, and no chemotherapy combination or a single drug gives us a good overall response rate or a disease control rate. So that is why it is an unmet need that we evaluate what is happening to this tumor and find out if we can have the target molecule or a target mutation. So FGFR2 or 3 mutation are frequently found in the bladder cancer, which is to the tune of approximately 50 to 56%. And looking at that data, so this trial evaluated how to sequence these drugs. So sequencing edrafitinib is the drug which is FGFR TKI, FGFR TKI, and enfortumab vedotin is the Nectin-4 inhibitor ADC. So these two drugs have been in the pipeline, and there has been a real world phase 3 data where pembrolizumab plus enfortumab vedotin has shown a greater benefit in all the subsets in the first line compared with the chemotherapy. So that is the trial which we will be discussing after this. So the unmet need for the data sequencing on of edrafitinib was and enfortumab vedotin for the patients with FGFR 2 and 3 altered advanced metastatic urothelial malignancies will be discussed here. The preclinical data suggest FGFR inhibition increases the Nectin-4 expression. So that is why it is believed that sequencing the drugs in edrafitinib followed by enfortumab vedotin may give a better response. So this is what was evaluated in the trial. So it was a multi-institutional study. Total of 630 patients were included, among whom approximately 490 patients had the NGS database available, and 94% of the 94 patients had FGFR 2 or 3 alterations which were present. So the patients were started on edrafitinib followed by enfortumab vedotin on progression or vis-a-vis. Then there was the third line where the patients received only enfortumab vedotin as a monotherapy. So the study endpoint was the overall survival from the starting of the therapy, PFS from the starting of the therapy, and the overall response rates. They've excluded the third arm and compared the other two arms. So the baseline characteristics of the population were fairly well matched, and it included 60 to 67% patients involving the bladder tumor and 33% of the patients in the upper urinary tract involvement. So, and look at this table and the lower lines. The prior anti-PD-1 therapy was used in approximately almost 90 to 100% of the patient, and platinum based chemotherapy was used in approximately 50% of the patient initially. So when we looked at the sequencing, so either giving FGFR inhibitor followed by enfortumab vedotin or vis-a-vis, the median overall survival is almost the same, 21 months versus 19 months, and median progression-free survival is again the same. The overall response rates are slightly better with sequencing enfortumab vedotin and then edrafitinib. So there the response rates becomes double. But again, looking at the overall survival benefit, it does not make much of a difference that you use either FGFR inhibitor prior to Nectin-4 ADC or later on. So this was the univariate and the multivariate analysis. And again, it shows that the p-value is not very convincingly different. The important aspect is edrafitinib versus followed by enfortumab vedotin versus EV as a monotherapy. There was a better p-value. Otherwise, most of the places the p-value was not significant. And the patients who have received a prior anti-PD-1 therapy versus no anti-PD-1 therapy, the patients who have not received any PD-1 therapy, the responses have been even greater. So they concluded that the higher OS was observed in the patients with advanced urothelial carcinoma and FGFR2 or 3 alterations treated with idrapatinib and EV, regardless of the sequence. Investigators suggest that this may reflect selection and guarantee time-based bias and note additional limitations of the sample size. No significant difference in the median PFS. Additional studies are needed now that EV plus pembrolizumab is a new standard of care for the first-line urothelial carcinoma. Sequencing and the tolerance should be explored more. So now, so that is all in this abstract. So as I have said, pembrolizumab and EV has become a newer standard of care. So I would like to invite my colleague and next speaker for the talk, which will be given by Dr. Priyanshu Chaudhary. Dr. Priyanshu, are you there?
Yeah, I'm here.
Yes. So Dr. Priyanshu is a consultant medical oncologist at IVY Hospital Mohali. So he'll be talking about Keynote A39 trial or EV02 trial, which has come up again in the abstract form. And if we look at the data, it is very convincing. Yes, we need to follow it up, and definitely we can change quite a lot of things with this trial. Over to you, Dr. Priyanshu, for your presentation.
Thank you, Dr. Nitish, and good evening, everyone. So, can somebody share my slides?
Yes, sir.
Yeah, so I'll be talking about the phase 3 EV302 Keynote A39, the subgroup analysis of enfortumab vedotin plus pembrolizumab versus chemotherapy in previously untreated advanced urothelial carcinoma. Next. So these slides have been provided to me by the organizers. Next slide. So coming to the background, the median overall survival for advanced urothelial cancer is approximately 13 months, with the platinum-based chemotherapy providing optimal outcomes. Not all patients are eligible for platinum-based chemotherapy, and additional therapies are needed to improve outcomes for all the patients. This phase 3 EV302 or Keynote A39 trial compared EV plus pembrolizumab versus platinum-based chemotherapy in previously untreated locally advanced or metastatic urothelial cancers. EV plus pembrolizumab was approved by FDA to treat adults with locally advanced or metastatic urothelial cancer based on improved median PFS and OS. In the phase 3 EV302 trial, this report presents results of pre-specified subgroup analysis from phase 3 EV302 trial. Next. So this is the study design. The patients with locally advanced metastatic urothelial cancer with no prior systemic therapy except for neoadjuvant or adjuvant chemotherapy, pre or post cystectomy, and recurrence more than 12 months after the end of therapy. They were eligible for platinum and enfortumab vedotin and pembrolizumab and PD-1, PD-L1 inhibitor naive with a GFR of more than 30 ml per minute and an ECOG PS of 0 to 2. So they were randomized to enfortumab vedotin day 1, day 8 of 3-week cycle, and there was no limit on the cycles, plus pembrolizumab day 1 of 3-week cycles up to 35 cycles. And the second arm, the control arm, had gemcitabine day 1, day 8 of 3-week cycles plus cisplatin or carboplatin on day 1 of 3-week cycles up to 6 cycles, and then progression with until disease progression or an unacceptable toxicity or completion of maximum number of cycles. So there was stratification based on cisplatin eligibility, liver metastasis, and PD-L1 expression. The primary endpoint was overall survival, progression-free survival by BICR, and the key secondary endpoints were overall response rate as per RECIST by the BICR and by investigator, duration of response, disease control rate, PFS, and safety. So the pre-specified subgroups were demographic data, baseline ECOG performance status, visceral versus lymph node only disease, and primary site of disease origin. Next. So these were the overall PFS and OS data in the intention to treat population. The median survival follow-up was 17.2 months. And if we see the median PFS as per the BICR in the EV plus pembrolizumab arm is 12.5 versus 6.3 in the chemotherapy arm. Hazard ratio of 0.45 is significant. And the median overall survival 31.5 months versus 16.1 months with a hazard ratio of 0.47, again significant p-value. Next. Now coming to the subgroup analysis, the PFS according to the various subgroups. So if we look at the first subgroup, that is the cisplatin eligibility, so it benefited both in patients who had cisplatin eligible or ineligible disease. So the hazard ratio slightly better, 0.43 in patient with ineligible, and the numerically median PFS 10.6 versus 6.1. In the one who were eligible, 14.6 versus 6.5, hazard ratio 0.48. Again, it benefited both the subgroups of PD L1 expression less than 10 or more than 10 CPS. Again, the hazard ratios are 0.42 for high CPS and 0.50 for low CPS. Benefit was present in both patients with liver metastasis or yes or no. So numerically, definitely patients who don't have a liver metastasis did well, 16.4 versus 6.4, and in patient who have liver metastasis, 8.2 versus 6. So hazard ratios again significant both for both subtypes, 0.43 and 0.53 in patient without liver metastasis and liver metastasis respectively. Next slide. Again, if we see PFS among other subgroups, it is not crossing the confidence intervals are not crossing unity, so it is significant for all the subgroup, whether it's age less than 65 or more than 65. Race, in the race, if we see non-whites are doing numerically as well as statistically better, 22.3 versus 6.5. Similarly, if we see the geographical region, rest of the world is doing better. Median PFS not reached versus 6.2 and a hazard ratio 0.35, which is one of the best we've got for bladder cancer. Males and females both are benefiting. Females numerically slightly less, probably because of the lower numbers. And definitely the performance status 0 patients are benefiting numerically better, 22.3 versus 6.7. PS1 to 2, 9.3 versus 6.1. Similarly, the patients who have the site of disease doesn't matter. Again, numerically almost similar, 12.7 versus 6.2 for upper tract and 12.5 versus 6.3 in the lower tract. For the visceral disease, yes, definitely numerically 10.4 versus 6.2. For lymph node disease only, the median PFS was not reached versus 8.3. So all these are probably, visceral disease and a poor PS are, overall, if we see they are bad prognostic factors. So the benefit is there. The numerically benefit might not be as high as patient without these factors. So it is also benefiting patients in all types of renal parameters, whether it's normal or there's mild to moderate or severe renal dysfunction. So the hazard ratios are pretty similar. Next. Now coming to the overall survival subgroup analysis, if we see again all the subgroups are benefiting. For cisplatin eligible 31.5 versus 18.4, and for cisplatin eligible the OS was not reached versus 12.7. PDL1 high 31.5 versus 16.6, and PDL1 low not reached versus 15.5. So slightly paradoxical here. Liver metastasis present 19.1 versus 10.1, and without liver metastasis OS was not reached versus 17.9. Next. So again, if we see every subtype is benefiting except for probably geographical region. If we see North American patients, OS data, the hazard ratio is crossing unity. Otherwise, all age groups less than 65, more than 65, they're benefiting. Whites, non-whites. Again, OS is better in non-whites and the rest of the world too, where the median OS is not reached. Sex, male, female, both are benefiting. ECOG, again, PS0 OS not reached, and in PS1 to 2, 25.4 versus 13.1. Similarly, both upper and lower tract are benefiting. Visceral, non-visceral, both are benefiting. Lymph node only, OS was not reached versus 27.5 months. And all types of renal function patients are benefiting. Next. So the coming to the overall response rate by BICR based on the stratification factors and sites of metastasis. So if we see the response rates for cisplatin eligible 70.8 versus 53, and absolute difference of 17.8%. Platinum eligible 63.9 versus 34.9, and 29% absolute difference. So this is an important factor in patient who are cisplatin eligible. If we need a good response, so this combination is very effective. For CPS high and low, again responses are better with EV plus pembro. 71.1 in high PDL1 versus 46.6. Low PDL1 63.3 versus 41. Liver metastasis again 60 versus 41.4. Absolute difference 18.6. And without liver metastasis 70 versus 45.3. And visceral only metastasis 64.1 versus 39.6. And lymph node only 77.5 versus 53.4. Next. So now coming to the overall safety. So there were no new safety signals for EV or pembrolizumab. The grade 3 or more adverse events were observed in 56% of the patients receiving EV plus pembro versus 70% of the patients receiving chemotherapy. So if we see EV plus pembro, asthenia, diarrhea, immune-related mediated lung disease, multiple organ dysfunction. These were the adverse events leading to death. And in chemotherapy, it was febrile neutropenia, myocardial infarction, neutropenic sepsis, as well as sepsis. Overall, if we see grade 1 and 2, as well as the grade 3 and 4 are similar. Chemotherapy grade 3 and 4 are actually higher compared to EV versus pembro. So if we see the major grade 3 side effects in EV plus pembro were peripheral neuropathy, rash, fatigue, diarrhea, neutropenia, anemia, and other less common were pruritus, alopecia, decreased appetite, nausea, as well as thrombocytopenia. So neutropenia, anemia, and thrombocytopenia, that is hematological toxicity, was more common with chemotherapy in grade 3 compared to EV plus pembrolizumab. Next. So the investigators' conclusion were that benefit with EV plus pembrolizumab versus platinum-based chemotherapy was observed across all predetermined subgroups. Similar benefit for patients regardless of cisplatin eligibility. Benefit was consistent with overall survival and PFS results in the intention to treat population. No new safety signals were observed. And results from subgroup analysis of phase 3 EV302 Keynote 839 further supports EV plus pembrolizumab as a new standard of care for first-line treatment of locally advanced or metastatic urothelial cancers. Next. So thank you, and over to the organizers.
Thank you, Dr. Priyanshu, for this wonderful discussion of the abstract. So we have seen that EV plus pembro has shown a great benefit in almost all the sites, whatever we talk about. So I would like that we can discuss the questions or answers in the next panel-based discussion. So it is a case-based discussion on management of metastatic urothelial carcinoma. And I would like to call upon my moderator, Dr. Deepak Singla, sir. He is a consultant medical oncologist at Indus Hospital, Tri-City. So, sir, you can invite your panelists, and over to you, sir.
Yeah. Good evening, all, and thank you, Dr. Garg, for giving me this opportunity. So my job has been, majority of my job has been done by my previous speaker, and now we will be discussing about advanced and metastatic urinary bladder. Case-based discussion, and for this, I would like to invite my panelist, Dr. Mukesh Bansal, who is a consultant medical oncologist at Alchemist Hospital, Panchkula. Dr. Mukesh, are you there?
Yeah, good evening, sir.
Yeah,
Yes, I'm there, sir.
very good evening. And Dr. Jagdeep Singh, who is consultant medical oncologist with AOI Amritsar. Dr. Jagdeep,
I think
Jagdeep,
Dr. Jadeep is not there.
okay. Dr. Kanika Sharma, she's a consultant medical oncologist with Max Mohali. And Dr. Neha Gupta is also a consultant Max Bathinda. Yeah, Dr. Kanika, are you there?
Yeah, good evening, sir.
Good evening. And Dr. Neha Gupta, Dr. Neha?
Yes, sir. Good evening, sir.
Okay, good evening. Very good evening. So let's start with Nishant. Please move the slide, please. Next slide, please. Okay. So basically, what we're discussing is what is the chemotherapy first line and what is the second like immune check inhibitor we use post chemotherapy in the maintenance, and whether we can use immune check inhibitor in first line. If yes, then when and how. Next slide, please. Nishant. Nishant, next slide. So basically, this is a gentleman, a 74-year-old male, ex-serviceman, army man, and ex-smoker. Now he has quit the smoking, and there is no comorbidities. He was evaluated for painless hematuria, and his performance status is 1, and there is no diabetic, there is no hypertension, no comorbidities. And when the ultrasound was done, when there are multiple soft tissue polypoidal growth are noted in the urinary bladder. In the left lateral wall and the posterior wall, the largest growth was there 3.9 into 2.8 centimeter in the left lateral wall, but there was no hydrouretronephrosis. The patient underwent URBT, which was differentiated high-grade invasive urothelial carcinoma. Tumor invades the underlying muscularis propria, LVI, PNI not seen. So for the staging workup, the patient had undergone PET CT scan, which is suggested of disseminated disease with the pelvic nodes, retroperitoneal nodes, plus mediastinal nodes, multiple lung mets, and CBC is okay, and KFT is also good. Creatinine clearance is 75 ml per minute, and ejection fraction is 66%. Uh, and the diagnosis is metastatic high-grade urothelial carcinoma. So I just would like to know from my panelists at this stage if you want anything else apart from this workup. Dr. Kanika, you can take on this. Anything else you want to do?
So we can do a baseline PDL1 status also, but irrespective of it, patient is cisplatin eligible. So I would like to start with chemotherapy alone. Start with chemotherapy and.
No, I'm not. No. I'm not coming to the treatment part. I'm just asking about the workup part. So you said the PDL1 testing should have been done on the baseline.
Yes, sir.
Okay, and Dr. Neha, anything else?
No, sir. PDL1 testing only should be done at this point of time.
At this point of time, okay. And Dr. Bansal, Mukesh,
No, sir.
Dr. Mukesh?
No, sir. I think that's sufficient, sir, for me.
That's sufficient. Nishan, next slide, please. So, how will you treat, Dr. Neha? So, what is your treatment of choice at this
So
point?
in my own
I
clinical
mean, out of
practice.
5.
Yes, sir.
Sorry.
Yes, sir.
So, what is your treatment of choice? Gemcis, Gemcarbo, MVAC, and this immunotherapy upfront, and single agent cisplatin. What is your choice?
So in my clinical practice, as this patient is 74 years old and the patient is cisplatin eligible, I will go for Gemcis.
Okay, you will go for Gemcis.
Yes,
okay, okay. And what I mean, how do you? How do you determine the eligibility for the cisplatin?
So according to the performance status, performance score is 1, and then come the creatinine clearance, which is more than 60, and the creatinine clearance, which is more than 60.
Okay.
And the patient is having no comorbidities, so I'll go with Gemcis.
Okay, okay, very right, very right. Okay, and Dr. Mukesh, anything else you want to add on?
No, sir. I think I will like to go with Gemcarb in this patient, gemcitabine carboplatin, as a metastatic setting. We are not in curative setting. 74-year-old gentleman. Cisplatin can be given, but practically I am using carboplatin in these patients.
Very Dr. Kanika, what is your choice? What will
So
be your choice?
gemcitabine cisplatin only is the first line.
No, platin. Which platin?
Cisplatin, sir.
Cisplatin. You will go ahead with the cisplatin in 75-year-old male.
So maybe
Okay?
day 1, day
Yeah.
8 modified dosing, but still cisplatin.
Yes, modified dosing. Yes, we can give
Yeah.
that. Okay. So next slide, please, Nishant. Yeah, next slide, please. So, Nishant, next slide. So this is a cisplatin eligibility. ECO performance status 2 or greater, creatinine clearance less than 60, and hearing loss. And the audiometry should have been done on the baseline. And a grade 2 or a greater peripheral neuropathy, whether sensory or whether it is this, but not interfering with the activities of daily living. So, are you doing the audiometry routine when you are using any platinum routine basis?
No, sir.
Dr. Neha, you can take on. Yes.
No, sir. We are not doing in the routine at the baseline. Only if the patient is symptomatic, we go for that. Otherwise, we don't do at baseline.
Okay. Symptomatic. Only in the symptomatic. Right. Dr. Mukesh?
Same, sir. Only in the symptomatic patients, not in as a routine.
And NCV?
Same, sir.
And
Only if there is doubt, only if there are sufficient symptoms, not as a routine.
Okay, right. Dr. Kanika, you will be agreeing with that?
Same, sir. Since patient have no comorbidity, no long-term diabetes or hypertension also, so not routinely. I'm not doing it.
Not routinely. Okay. Yeah. Do you have any? How many subset of your patient who has reported the hearing difficulty after starting the cisplatin or carboplatin? And do you come across to that?
So
does it happen to any of
more
your
with
patients?
the head and neck cancer patients, they do present. One of our patients presented with tinnitus after starting of cisplatin, and once we changed it to carboplatin, the patient improved. So yes, patient do complains of hearing difficulties and complaints after starting cisplatin.
Okay, very good. Okay, next slide, please. Nishant, next slide, please. Nishant, next. Okay, so you have already answered that either Gemsys or Gemcarb. Any of them you can choose. Mukesh want to use Gemcarb, and the remaining two consultants want the Gemsys. Okay, next slide, please. Yeah. So if we look at the cisplatin-based regimen in the metastatic bladder cancer, so Gemsys is having a overall survival of 14 months, and this is a maximum which we can get in any of the doublet. And remaining HDVAC, which is highly toxic. I don't know. I don't think so that any of us are using. Gemcarbo has an overall survival of 9 months. So, if the patient is eligible for a cisplatin, we should go ahead with the Gemsys. Very right. Next slide, please. Next slide. So, if I give, if this patient, okay, second scenario, if the patient is having a type 2 diabetes mellitus, diabetic nephropathy, creatinine is 1.9, creatinine clearance is 35 ml per minute. So, which will your preferred regimen? Why? Dr. Mukesh.
Sir, the disease is metastatic or what is the status? It's a metastatic disease?
It's a metastatic disease. Yeah.
Okay. And type 2 diabetes, nephropathy, Gemcarb. Or we can go for immunotherapy if the patient is affordable. Gemcitabine, carboplatin, or sir, immunotherapy can be given.
Okay, no, affordability is not a patient is impaneled patient, and government is
okay,
approving
but
all the IOs.
The preferable will be gemcitabine, carboplatin for me.
Okay. Not the ICI.
No, not exactly, sir. No, not exactly.
No. Okay.
I will still
Kanika, what
prefer
about
them.
you?
Yeah.
Kanika, what about you?
Sir, again, would like to see the PDL1. If a PDL1 is positive, elderly patient with cisplatin ineligible, I would go ahead with pembrolizumab single agent.
Okay. And you want to, Dr. Neha, are you there?
Yes, sir. Same, sir. I would like to go with Gemcarbo if patient is not affordable. If the patient is affordable and PDL1 is more than 10, CPS more than 10, then I will like to go with single agent pembro.
Single agent pembro, very right, right, right. Okay, next slide, please. So if we use, frontline checkpoint inhibition in cisplatin ineligible urothelial cancer, it's a single arm trial and the keynote 52 and this MBGO 210. The overall response rate with the pembro, pembro is 29% versus with eto 24%, and median OS is 11.5 versus 29 with the atezolizumab, and median OS is 11.5 versus 16.5, and 12-month overall survival percentage is 48 versus 58%. Yes, definitely if the PDL1 is more than 10%. Next slide, please. So the patient treatment option for the cisplatin eligible patients are, all are correct. Gem carbo can also be given. Pembrolizumab keynote 0.052. If the CPS score is less than 10, it is only 20% response rate, and if more than 10, 47. And with the atezolizumab, it is 23%. 23%, but highest response rate is with a 41%. Yeah, next slide, please.
Yes, I have a question. Is the pembrolizumab approved for cisplatin ineligible or any platinum ineligible in first line metastatic? I'm not
Sorry?
sure actually. Sir, we are using the first discussing the first line metastatic option. Is the pembrolizumab approved for cisplatin ineligible or any platinum ineligible? Means the patient has to be ineligible for carboplatin also, because I think it is for platinum ineligible patients only. We can give, but the guidelines say I think is for the platinum ineligible patients only.
Okay, right.
But
right.
platinum ineligible is usually used for cisplatin only. I don't think.
No,
So
no,
now,
it means
now
carboplatin ineligible also.
I can answer that. So the thing is, it has changed in the recent era. In 2024, the patients are divided into cisplatin ineligible, platinum ineligible, then comes the other thing. So if the recent most data which Dr. Priyanshu presented, that was the trial which has shown that across all the borders or everything, whatever ineligible we are talking about, you give pembro plus enfortumab vedotin, it is going to work, and the response rates have doubled. So that is the beauty of these two target drugs. And the keynote 052 data Dr. Kanika has already presented, and even that has shown that the responses are there, either the patient is ineligible or eligible. So you can always use PDL1 expression and use pembrolizumab, but now combination is a better choice.
I think Dr. Nitish, you are talking about pembro plus EV. I think here the option is only single agent pembrolizumab. I think for that the guidelines are a little bit different, as far as I know. I may be wrong. What is the view of the other panelists and moderator?
That's what the keynote 52 trial is, I think, for most of the patients.
That is the combination is a different thing. Single agent pembro, I think it's for platinum ineligible only, as far as I know.
Okay, okay. I think Mukesh, your answer will be answered in the subsequent slides as well.
Okay.
Let's have a look. Hai na? Okay. So how frequently do you do the test for PDL expression for deciding the treatment in cisplatin ineligible patients? And what are the methods or antibodies you use? Which platform you are using for the PDL1? And how frequently you are doing it? Kanika?
So sir, if the patient is affordable, then in all the patients, I'm doing PDL1 at the baseline in bladder cancer and using the IHC for CPS score testing by SP42. IHC, sir.
Okay, IHC method, right. Mukesh? Dr. Mukesh?
Yes, sir. I'm not routinely doing PDL1 testing, sir, in bladder patients. And if I'm doing it by ISC and by 22C3 DECO platform.
DECO. Okay, right. And Neha, same?
Yes, sir, same, because patient are not affordable for PDL1 testing in the upfront
Okay.
dose. Yes, sir.
Okay, right. Nishan, next slide, please. Type not fit. Okay, if the patient is not fit for the chemotherapy, what will be your preferred options? Best supportive care, pembro, or atezolizumab?
So depend on the
Next slide.
affordability criteria.
Next slide, please. Okay. So, Dr. Mukesh, I mean, what will be your choice? Go to previous one. निशांत पहले वाली स्लाइड में जाना यार. हाँ.
Sir, I think that depends on the patient. It can be immunotherapy or best supportive care. If the patient is affordable and PS is at least 2, then we can try immunotherapy either in the form of pembrolizumab and atezolizumab. Otherwise, if PS 3 and 4, then obviously best supportive care.
Best supportive care. Okay. And atezolizumab, I mean, irrespective of the PDL1
Yes,
state.
sir. Yes, sir. I think both are irrespective of PDL1 as far as I. Yeah.
And Kanika, what about you?
So same, if the performance status is good and the patient is able to take care of himself and not bedridden, then immunotherapy. I would like to give a trial of immunotherapy in this patient.
Okay. Neha, same?
Yes, sir.
Right. Okay, right. Okay. Next slide, please. Okay. So our patient is again, no, he has received already 6 cycles of Gemcis and partial response, but there is a disease progression at the 9 months. So so what we are going to do post platinum progression. So Mukesh, what will be your choice to post platinum progression? You want to start with another form of chemotherapy, or you want to give the immunotherapy? What is your choice?
Sir, immunotherapy in this patient.
Immunotherapy, yes.
Yes, sir.
Which one?
Pembrolizumab, sir.
Yes.
Keytruda. Yeah.
Pembro.
Yes.
Okay. Right. Dr. Kanika?
The same.
Same. Pembro. Okay. And Neha also agree for that?
Yes, sir. Yes, sir.
Yeah. Okay. Next slide, please. So let's see how Pembro works. How much is the question? So everyone is agreeing that they want to give the immunotherapy, whether it's a Pembro or okay, majority of agree on the Pembro. Okay. Why not chemo? So okay. Poor response rate.
So 9 months PFS, already elderly patient. So why to give toxicity of another chemotherapy? Better to start neuropathy.
Right. Next slide, please. Next slide. So let's see. So if we see the overall response rate with the pembrolizumab, it is more than 21%, and while with the chemotherapy, it is only 10%. It's with the chemotherapy, it is only 10%, and with the pembro, it is the highest one. Next slide, please. Okay, if we are seeing the overall survival percentage, and this is also maximum. I mean, this is also 43.9% with the pembro and 26% with the chemotherapy arm. Right. Next slide, please. Next slide. Yeah. So go to previous one. So this is a keynote 045 study design. I think Dr. Kanika has already been discussed. I will go fast. Adult patient with predominantly transient cell urothelial cancer in a pelvis ureter, 1 to 2 lines of platinum-based chemotherapy or recurrence less than 12 months after the perioperative platinum-based chemotherapy, randomized into pembro versus chemotherapy, and treatment continued for the 2 years unless progressive disease or unacceptable toxicity. Next slide, please. Primary endpoint was OS and a PFS. So post-platinum urothelial over is 12%. So with the chemotherapy arm, it was 26%, and with the pembro, it was 43.9%. Okay. Next slide, please. Nishant, next slide. Okay. So if we see this overall survival percentage, overall survival was 44.4%, and percentage over at the end of 12 months, while it was 30.3%, 30.3% with the chemotherapy arm, and this overall median OS was 10.3 versus 7.4. But the thing is, the curves remain separated till the end also. Yeah. Next slide, please. So overall response rate also 21.1%, and with the all patient with the patient with the CPS score of more than 10, it is 20.3%, and again chemotherapy is dismal 11% versus 6.7%. Yeah. Next slide, please. So I mean. Out of out of all my panelists, who are using this atezolizumab instead of pembrolizumab? I mean, how frequently you are using, or we are still stick to the atezolizumab? Kanika?
So I've not used atezolizumab in bladder cancer yet, actually.
Okay, right, very right. Mukesh? No?
No, sir, not used in the bladder.
Not used. And Dr. Neha? I think
Yes, sir, same, sir. Not used.
Not used it. Okay, me too. I mean, I have not used that. So basically, key eligibility criteria is remain the same. Metastatic UC, progress on platinum-based chemotherapy less than 2 or 2, and ECO PS1, and evaluable sample for PD-L1 testing, randomized into 1:1 atezolizumab versus chemotherapy, and this it was. Atezolizumab was continued till the loss of clinical benefit, and this chemotherapy was RECIST criteria as response rate was evaluated by RECIST and versus progression. Next slide, please. Okay. So overall, there are overall survival with atezolizumab 11.1 months versus 10.6 months. I mean, more or less the same, and median OS was 11.1 versus 10.6, and 12 months of overall survival data of 46% versus 41%. There is not much difference. The only thing is that patient who has responded, they remain to be they kept on responding as the curves are not meeting each other. I mean, till it remains separated till at the end also. Next slide, please. Next slide. So these are the various checkpoint inhibitors which Kanika has already spoken about. To conclude that first-line therapy of the metastatic is chemotherapy is still active, and cisplatin eligible patients should get cisplatin. And FDA and EMA warn the decreased survival with the first line of IO in cisplatin ineligible patient with low PD-L1, assessed by the appropriate companion diagnostic test. And access to such diagnostic tests is variable, limited at many institutions. Next slide, please. So, okay. So how many out of you are using the switch maintenance immunotherapy in metastatic bladder cancer? Mukesh? And after how many cycles? How many cycles you give and before switching the patient on the maintenance IO?
So I prefer to give 4 to 6 cycles. If the patient is responding well, tolerating it well, then I go for 6 cycles. Otherwise, after 4 cycles, I switch to immunotherapy maintenance.
Okay. Okay. Which immunotherapy?
Sir, avelumab.
Avelumab. Very good. Okay. Okay. And Kanika, same?
Same, sir.
Okay.
If tolerating well, I'd like to complete 6 cycles and followed by avelumab maintenance.
Avelumab. Very right. Okay. And which dose you are using, Dr. Neha? If you are using the avelumab as per Javelin 100, I mean, which dose you are using? How much dose you are using? Mukesh? Hello?
Yes, sir.
Mukesh?
Sir, 800 mg, sir. 800 mg, 2 weekly, sir.
Okay, two weekly. Okay, okay. And Dr. Kanika? Next
Same,
slide,
sir.
please. 800 mg to 2 weekly. Right, right. These are the trial checkpoint inhibitors as maintenance therapy, Javelin Bladder 100, and this is another one, SCRNGU 1. It's a still phase 2 study. In the Javelin 100, we know the primary endpoint was OS, and primary endpoint was PFS in the HCRN GU 14. Next slide, please. Next slide. So now the last, we are coming to the end. This next, go to previous one. Okay, so now coming to the this ADC and enfortumab vedotin in advanced urothelial cancer, previously treated with platinum chemotherapy and IO. So as we know, it's a ADC and which conjugate to Nectin-4 and deliver the cytotoxic MMAB to tumor cell expressing Nectin-4 and disturbing the microtubules, resulting in the cell cycle arrest and apoptosis. Next slide, please. So, are you convinced with this study, Dr. Kanika, EV201 study design? Although it is the phase 2, but
yes, I don't have any problem with the study design, just the availability of the drug. So I have no as such experience of using this drug. Yeah.
yes, the same. I think in India it is still not. It is still not available, right?
I think some trials are going on, but it's not available as of.
It's not available. Okay, next slide, please. Next slide. So if we see the overall response rate, it is quite impressive, and PFS is 5.8 months, and median OS is 11.7 months. Next slide. Nishant, next. So first line cisplatin eligible, cisplatin based combination chemotherapy should be given. Ineligible PDL testing as per recommendation. If the PDL1 is high, then consider immunotherapy. If the PDL1 is low, not available, then carboplatin based chemotherapy can be considered. And first line chemotherapy ineligible can consider immunotherapy. Second line, we have 5 IOS drugs, some data for use in the metastatic UC, but only one with the phase 3 data to support its use is Pembro. Third line is enfortumab vedotin appears promising in phase 2 trial, but it is not approved yet. So accelerated approval does not guarantee the phase 3 trial success. And more IO drugs and combination trial are ongoing. Cost will play a big role, especially in our country. Next slide, please. Yeah, that's all. Thank you very much for patience hearing. Yeah, over to the Dr. Nitish.
Thank you, Dr. Deepak, for this session moderation, and definitely there was a good discussion, which was happening on urothelial. The newer data is going to change the standard of practice once the EV is available in India, and the data has been extremely beautiful. The responses have been great, almost doubling up of the response, the PFS, the overall survival in the Pembro and EV combination compared to chemotherapy. So just a quick word, we have never talked upon that there is a trial of checkmate, I believe, in nivolumab plus gemcitabine plus cisplatin versus only cisplatin, which was approved as a first line setting. So does anyone use that or not? So just a quick question on.
I've not used it, but yeah, the patient who have a high disease burden, I would like to add something upfront with the chemotherapy for a better response, actually.
Okay, right. So now moving up the genitourinary tract from prostate, bladder to the kidneys now. So we will be talking about the role of immunotherapy in resectable RCC. And I would like to invite my dear friend, Dr. Mukesh Bansal. He is a consultant medical oncologist at Alchemist Hospital, Panchkula, to deliver his talk. Dr. Mukesh,
Thank
over
you,
to
Dr.
you.
Nitish. Thank you, Dr. Nitish. Thank you for inviting me and giving me this opportunity. Good evening, everyone. Can someone share the slides?
Yes, sir.
Yeah, yeah, please. So the topic given to me, I will say a little bit difficult topic. The role of immunotherapy is basically in a resectable RCC. As we know that renal cell carcinoma doesn't respond to chemotherapies. So immunotherapies from last few years have assumed greater significance in RCC. So, as they have been established as a standard of care in first line metastatic settings, now the trials are going on to incorporate them in adjuvant and as well as in neoadjuvant setting. So, we can improve the survivals of resectable and curable renal cell carcinomas. Many of the previous trials with sunitinib and other tyrosine kinase inhibitors and chemotherapies have failed. But in this, one of the most promising and exciting trial, I will say, is Keynote 564, uh, which focused on the role of adjuvant pembrolizumab versus placebo after nephrectomy for renal cell carcinoma. Others trials of immunotherapy were either failures or they are in the actively recruiting phase and the data is yet to be released. Next slide, please. So again, the first we will discuss about the successful trial which have been incorporated into guidelines. Next. Yes. So globally, around 1,80,000 deaths due to kidney cancer happened in 2020. The standard of care treatment for locoregional, localized, and even till few years back for metastatic or oligometastatic patients were nephrectomy. Standard adjuvant therapy supported by high levels of evidence is not yet there. Studies of adjuvant VEGF targeted therapy and immunotherapy with cytokines have produced equivocal and mostly negative results. Disease recurrence, if we see, is around 50% in patients after surgery. So there is an unmet need. Uh, what to do after surgery, how to improve the survival rates further. Risk factors for recurrence include tumor stage, size, the involvement of the lymph nodes, the grade, M1 stage with no evidence of disease after resection, also at elevated risk of recurrence. And current study evaluated adjuvant pembrolizumab versus placebo for patients with clear cell RCC after nephrectomy. Next slide, please. So first, I think few of the trials which resulted in negative results. There was IM Motion 010 study where atezolizumab 1200 mg 3 weekly were used in intermediate risk and high risk groups. They defined the intermediate risk as T2 grade 4 or T3A grade 3 grade 4 patients or metastatic patients or T4 patients. But that result trial was negative. There was no improvement, significant survival benefit with the use of atezolizumab. Then there was another trial of nivolumab plus ipilimumab, checkmate 914 study, which also used nivo-ipi in the high risk and intermediate risk groups. But again, the results were not statistically significant. Benefit was not there, and that result trial was also negative. Then came this study, Keynote 564. It was a randomized, double-blind phase 3 trial of adjuvant therapy. Data cutoff date was December 2020. Median follow-up of about 2 years is there. So the eligibility criteria, patients with histologically confirmed clear cell RCC. So this trial limited uh, uh, into only clear cell RCCs only, and nephrectomy less than 12 weeks prior to randomization. So within the 3 months after surgery, you have to randomize the patients. No previous systemic therapy was allowed. ECOG performance status should have been 0 and 1. PS2 was not allowed. Tissue sample for PDL1 assessment was required. So pembrolizumab in the standard doses of 200 mg 3 weekly was given. In the second arm, placebo was given. So pembrolizumab was continued for 1 year in this study. So stratification was done by M0 versus M1 status. M0 group was further stratified by ECOG 0 versus 1 status. So primary endpoint was disease-free survival rate as per investigator. Secondary endpoints were overall survival and safety data. P-value boundary for statistical significance was 0.0114. Next slide, please. So if we compare the baseline characteristics, they were quite comparable and similar. Median age was 60 years. As we know, RCC is a tumor of elderly. Male, it's a male preponderant tumor. So around 70% of the patients were male in both the groups. ECOG 0 patients were in majority, around 85% of the patients. I think in RCC, usually in the resectable or curative settings, we do get a lot of ECOG 0 patients also. So that reflected in the trial. Disease risk category, non-metastatic patients with intermediate to high risk were around 86%, M0 high 8%, and only 5% of the patients were metastatic, upfront metastatic. Geographic location, North America, European Union, and rest of the world was also represented in about 35% of the patients. PDL1 status, which is an important marker in most of the immunotherapies. So CPS less than 1, 25% of the patients, more than 1, around 3/4 of the patients. Sarcomatoid features were present in about 10% of the patients in both the groups. Next slide, please. So disease-free survival, the primary endpoint, if we see the curves started to separate early within 3 to 4 months of the uses, and they continued to be separated even after 3 years. So at 12 months, 85.7% versus 76.2%, a benefit of around 9 and 9.5%. At the end of 2 years, 77.3 versus 68.1, again about 9 months. So the benefit was maintained. The hazard ratio came out to be 0.68, which is, I think, not bad. It's good considering this study came after so much failures in adjuvant RCC. Next slide, please. So disease-free survival by subgroup analysis, less than 65, more than 65, the benefit was there in both the subgroups, but the benefit was more in the younger group. Males, females both benefited. The benefit was mainly found to out to be in the ECOG PS0 patients. In one patient, it crossed the midline, so the benefit can be, it is doubtful basically. PDL1 status, CPS more than 1 benefited more than CPS less than 1. The maximum benefit was seen in European patients, but other patients also benefited. And even in metastatic patients, the benefit was there, although they were only 5% of the total population, but the benefit was significantly there. Next slide, please. So interim overall survival, if we see at the end of 1 year, 98.6 versus 98, 2 years, 96.6 versus 93.5. So about 3% benefit. 3 patients out in 100 patients benefited, survived more with the uses of this adjuvant pembro. Hazard ratio came out to be 0.54, which is, I think, beautiful considering the background. And p-value is 0.0164, which is significant. So interim overall survival benefit is there with the uses of adjuvant pembro. Next slide, please. Coming to the safety data, grade 3 to 5 side effects were there in about 1/3 of the patients in pembro subgroup and around 17 to 18% of patients in placebo subgroup. Treatment discontinuation was there in about 20% of the patients in pembro subgroup. Serious all-cause adverse events leading to treatment discontinuation, 10% versus 1%. Again, significant side effects were there in Pembro subgroup. Grade 3, grade 4 fatigue, diarrhea, and rash were observed with Pembro, while no deaths occurred on study. The main side effects seen with Pembro was fatigue, pruritus, hypothyroidism, diarrhea, rash, and others. So median duration of usage was around 11.1 months. So there is little probability of more side effects with the use of Pembro as compared to placebo. Next slide, please. So the immune-mediated adverse events, mainly hypothyroidism, as we all know, was seen in about 1/5 of the patients, around 20 to 30% of the patients. And pneumonitis, which is a dangerous side effect, was there in 2.3% of the patients, while other side effects were rarer. So use of high dose, more than 40 mg per day systemic corticosteroid treatment for immune-mediated adverse events in 7.4% of the patients in Pembro subgroup, it was required. Grade 3, grade 4 adverse events were uncommon. No deaths occurred due to immune-mediated adverse events. Next slide, please. So to conclude, it is the Keynote 564 is the first pre-specified interim analysis of the phase 3 Keynote 564 trial. Adjuvant Pembro achieved a statistically significant and clinically meaningful DFS improvement in patients with RCC post-nephrectomy. Hazard ratio was 0.68. DFS benefit was consistent across subgroups examined, including for patients with M1 metastatic staging and no evidence of disease. Overall survival data is immature. Additional follow-up is planned. Safety profile with Pembro consistent with previous reports. High-dose corticosteroid treatment for immune-mediated adverse events were infrequent. So investigators concluded that pembrolizumab may be considered a possible new standard of care for patients with RCC in the adjuvant setting. Apart from it, there are few trials where the data is yet to mature, but looks exciting. So there is a rampart trial with durvalumab 1500 mg. It's also planned in the adjuvant RCC setting. It's in the trial is happening. It's in the phase 3 part. And there is another prosper trial where nivolumab is being used in the 480 mg for weekly doses, where one cycle is being given in the neoadjuvant setting, then surgery is planned, and then 9 additional doses are being given after the surgery. So I think shortly, in few months, we will see the data of both these trials, and they may further add up to the adjuvant options in the RCC and may open up the new adjuvant settings in the renal cell carcinoma. Thank you. Thank you.
Thank you, Dr. Mukesh, for this wonderful talk on immunotherapy in resectable. So all the high-risk patients, more than T3 node positive disease, sarcomatoid features, I believe we tend to add immunotherapy in these cases, and pembrolizumab has definitely shown a response. So the update data, I believe there is a benefit compared to wait and watch strategy. So, moving to our last talk of the day, I would like to invite Dr. Kunal Jain. Sir is associate professor and head at my own institute. So he will be talking about paradigm shift in the management of metastatic RCC with immunotherapy. Over to you, sir.
Yes, good evening. I can only say Nitish and the team. Thank you for again inviting me for this talk. It was a good talk by Dr. Mukesh, and there is a recent update for adjuvant Pembro where there was a 5% absolute benefit in overall survival. So in adjuvant setting. So what I am going to do over the next few minutes, I was one of the opening batsmen yesterday, and I'll be closing the inning, so carrying the bat through with the last talk today, and mainly focusing on the metastatic setting. So we'll be covering these aspects. Quickly going through the epidemiology. we know that RCC mainly arises from the proximal renal tubular epithelium, more common in men, age group in 50 to 70, and majority of the cancers are clear cell cancer, which is what the previous trial was also focusing on. So out of all histologies, 3/4 are clear cell. And if we talk about the incidence, it's about 4.6 per 100,000 population, with about 2/3 occurrence in males. And if we talk about the global incidence, global burden, it's close to 430,000 cases annually. And the majority of the cases, as well as the mortality, happens in the Asian population. Some of the risk factors listed here are obesity, high blood pressure, family history, gender, because it's more common in men, and certain genetic diseases like we all know about VHL disease, BHD, Birt-Hogg-Dubé syndrome, and Cowden syndrome. BHD is an autosomal dominant disorder, and both Cowden and BHD have some skin lesions as well, and also associated with smoking. In India, the situation is not much different. More common, RCC is more common in men in the same age group, and we also see clear cell as the more common histology. Staging is pretty standard. Stage 1 disease limited 1 and 2 within the kidney, but look at the 5-year survival rate significantly dropping to 50% from 90% from stage 1 to 2. And that possibly is the rationale for using some strategy to improve the survival starting from stage 2 onwards. And stage 3, where there is in the nodes, stage and within same stage, even the histology can lead to a poor outcome, where clear cell does poor as compared to papillary RCC. And something that we should do and commonly do for most patients with advanced RCC is prognostic scoring, where initially MSKCC prognostic model and now International Metastatic RCC Database Consortium criteria, where 6 parameters are used, and patients are categorized into favorable, intermediate, and poor risk group. And if we see the NCCN guidelines, the preferred regimes for both favorable as well as for poor intermediate include TKI as well as immuno combination. And we have approval for axitinib, pembrolizumab, as well as for evolumab with axitinib also. But I think very soon nivolumab, cabozantinib will get the patient assistance program. And depending on if the patients have received previous immunotherapy, we can subject them to oral tyrosine kinase inhibitors, which are predominantly VEGF pathway targeting. And a new class of drugs where prior IO or especially both have been used is hypoxia-inducible factor 2 alpha inhibitors, which is belzutifan. Recently, it has been kind of compared. The comparator study was with the everolimus, and it showed positive results based on early data. The FDA has granted approval for this category of drugs. So what we will focus mainly on is the Keynote 426 study, where pembrolizumab axitinib was compared with then standard, which was sunitinib in RCC. You can see earlier we can divide the treatment strategies that we were using for metastatic RCC into various eras, like cytokine targeted therapy or in combination immunotherapy age. And currently we see plethora of immunotherapy either in single agent or in combination with the oral TKIs that we are using, which makes life more difficult for us and also for the patients, because the cost of treatment also goes. So the immunotherapy strategy is not new in RCC. We know there are spontaneous remissions because of immune modulated phenomena within the body, and earlier treatment with cytokines were there. Initial days of my oncology, there was interferon was the only thing which was available. I never used interleukin because, but this was one strategy which used to be considered as one treatment strategy where you can get complete responses. And then subsequently over the years, we have immunotherapy. So how this works, if we take the prototype drug as pembrolizumab, which is a humanized monoclonal antibody, which blocks the interaction between PD-1 and its ligands PD-L1 and 2. So because of this, you can see the PD-L1 and PD-L1-2 on the tumor cells cannot bind with the PD-1 present on the activated cytotoxic T cell, which can ultimately lead to its efficacy, and the T cells can act on the tumor cells, leading to its cytotoxic kill phenomena. So combination with axitinib, which is again a second generation targeted drug, potent and highly selective inhibitor of VEGF receptor tyrosine kinase 1, 2, and 3. And its advantages are its potency, little off VEGF receptor targeted effect, and we can up titrate or down titrate the dose depending on how the patients are tolerating it. And I'll not go into the rationale why it is used, and the dose of keynote of pembrolizumab that was used in this is quite standard. So what was the study design? 1:1 randomization of patients who were newly diagnosed or recurrent stage 4 clear cell carcinoma. No prior systemic treatment for metastatic disease. They needed to have a measurable disease, and patients were stratified according to the IMDC risk group into favorable, intermediate, or poor, and also according to the geographical area. Half the patients pembro plus axitinib in the standard dose of 5 milligram twice daily start dose. And if they were tolerating it well, then increase to 7 and maximum to 10 milligram BD. And if they were not tolerating, then to 3 or 2 milligram twice daily. And the comparator 50 4 weeks on, 2 weeks off. But currently we use 2 weeks on, 1 week off for most patients. Primary endpoints were both PFS as well as if we see here, the patient profile is kind of similar to what we would see. The intermediate risk category patients were more than half, and followed by a favorable, and then small, almost 10% of patient category, and about 18% comatologists, and 2/3 of patients had CPS score more than 1. And patients mostly had high metastatic burden with more than 2 sites of metastasis. So the initial study, when it was reported in NEJM in 2019, did show that there was difference of OS, which was reported both at 12-month mark and at 18-month mark, and the difference was about 10%. The sunitinib showed 72% survival at 18 months, and it was 82% in the pembrolizumab arm. So why median is not reported? Because both the drugs by that time had not reached the median mark, which was 50%. So both were doing better than that. But it showed that there was improvement in overall survival by about 47% relative risk. And area groups was benefiting across the subgroups, irrespective of age, gender, geographical area, risk category. Although if you can see in this, if you go from favorable to poor, the magnitude of benefit increases. So the minimum benefit is seen in the favorable risk category. And both PDL1 less than 1 and more than 1 did show benefit. This was a PFS which was reported. There was a median, a delta of about 4.5 months, which was reported 11 versus 15.4 months. Improvement in progression-free survival if the patients were given combination of pembrolizumab and axitinib, and similar forest plot showing improvement in all subgroups. So the subsequent 5-year follow-up study of data of the study, which was presented later on, did show that the benefit persisted. The PFS benefit was persisting at even we are talking about a 5-year mark, where about 1 in 5 patients were on similar drug. They were without progression. So 18% of patients without progression in this category, and sunitinib also not doing that bad, with 7% of patients still without progression. But look at the complete response rate. 1 in 10 patients can achieve complete response, and overall response rates were about 60% with this combination, as opposed to 40% with sunitinib. So definite improvement in response rates when we are giving immuno and oral TKI. And this was the duration of response, which also showed significant improvement from 15 months to 23 months with the combination. So the overall survival, there was a gradual tapering of the curves. And at the end of 5 years, the overall benefit, if we are seeing, or the difference in benefit, is about 4.5 to 5% absolute benefit. So this gradually is being lost over the time. Because most of the patients in sunitinib arm, almost in excess of 50%, did get second line immunotherapy as well at the time of progression. And if we take out the favorable risk group, which was the one which did not show significant benefit in terms of overall survival, if you can see at 5-year mark, the overall survival is kind of comparable, almost similar in both the groups. So maybe favorable risk category, we can consider only oral TKI and reserve this combination, especially in our resource constraint setting, for intermediate and poor risk category also. Although, as per this study, both the groups did show benefit. And in terms of subsequent anti-cancer therapy, patients in the immunotherapy group did get almost all of them, almost 87% did get a second VEGF inhibitor, and whereas in the sunitinib arm, almost 80% did get some form of immunotherapy, as I was mentioning earlier. So patients who completed, so the trial mandated that the cutoff was for 35 cycles of pembrolizumab, which would be 2 years of pembrolizumab, and after that, if the patients are doing fine, they will be continuing axitinib. And patients who completed 2 years of pembrolizumab, which would be patients who were obviously not progressing at the time of the median that we were showing, median progression-free survival in this group is about 15 months. So 50% of patients would have already progressed by that time, 15 and a half months. So the number was not very high. It was about 120 patients who completed 35 cycles of pembrolizumab. So this would also exclude patients who would be off treatment due to any toxicity, which was about 10% in the immunotherapy arm. But if we take only the patients who completed 2 years of pembrolizumab, look at the 60-month overall survival rate. It is about 70%. So almost 3/4 of patients are surviving 5 years if they are able to complete 2 years of pembrolizumab. So those who continue to respond do very well. And serious adverse events were not something new that was mentioned in this trial. Obviously, because of both the drugs, axitinib also we know causes VEGF pathway-related adverse events, and sunitinib did. It is a toxic drug, we all know, and especially in the 4-on-2 of schedule, it is not an easy drug to tolerate. So patients who discontinued this drug were about 13%, and discontinuation of any drug in the combination arm was 33%. So 1 in 3 patients would discontinue drug due to some reason or the other. So in summary, this trial represents the longest follow-up because we have a 5-year data now of combination of checkpoint inhibitor plus VEGF targeted TKI for the first-line clear cell RCC. And this combination continued to demonstrate improved OS, PFS, and overall response rate versus sunitinib. substantial percentage of patients completed 35 cycles of Pembro with good long-term outcome. And this data continues to support this combination as a standard of care for patients with previously untreated advanced RCC. I'll not go through the case detail. And with that, I'll end. And if there are any comments or closing remarks, over to you, Nitish.
Thank you, sir, for the presentation, the talk. So definitely, we all know immunotherapy has changed a lot of things, and the way of managing malignancies has changed since the advent of chemotherapy, initially in melanomas and then seeped into renal cell and hepatocellular carcinoma. So it is wonderful to see how these drugs are giving us a good response, and still we are waiting to further personalize the therapy so that we have a further improvement in the responses. So definitely, as you spoke about Basaltifan, so that was the drug which was initially used for von Hippel-Lindau syndrome, where it used to cause RCCs in kids. So there now it has come up into the second line or the third line setting for RCC. So thank you. And I think with this, if there are no more questions, with this, we end the session and end 2 days of our academic feast. So we have learned a lot about the genitourinary tract today, what is new happening. And yesterday we have discussed about GI malignancies and what are the regimens, what are the new things which are happening in that area. So I would like to thank my academic partners, Roche, AstraZeneca, Dr. Reddy's, Intas, Zydus, Cipla, Alchem, Fresenius Kabi, MCure, Smurth, Netco, and Ceylon Labs for the wonderful participation. And thank you, my technical team for and the organizing team for organizing the webinar so beautifully that they went smoothly. And I appreciate your effort. Thank you.
Thank you,
And
sir.
close
Thank you,
the
sir. Thank you, everyone. And thanks a lot for the excellent discussion and talks for this 2 days academic feast. Thanks to my colleague Nishant and Vishal and the technical team, Uday. Thanks, everyone. Good night, everyone. Till we meet again. Thank you, everyone.